On behalf of Oslo University Hospital, I would like to welcome you all to this PRC seminar called Next Generation Palliative Care Research, Integration and Implementation. My name is Nina Aas. I'm head of the Palliative Care Unit at Oslo University Hospital and professor in palliative medicine at the University of Oslo. Some weeks ago, we had a hope that there would be several colleagues from abroad and also from Norway together with us here in the premises of the Norwegian Cancer Society. But unfortunately, this infamous virus has made that impossible. But luckily for us, we know that more than 300 people will participate in this conference online. The Cancer Clinic at Oslo University Hospital is a comprehensive cancer center. Palliative care and patient-centered care are important aspects of what such a center should offer to their patients and their relatives. Department of Oncology is an ESMO-designated center of palliative care, and this is also a quality measure for the clinical activity and the research performed within this unit. We are therefore proud to host this seminar so closely linked to our work. Together, we will have 2 days with interesting presentations covering several aspects of the context of palliative care research. I hope you all will find this inspiring and informative, and I warmly welcome you to this seminar held or sent from Oslo. And then I will give the word to Professor Stein Kaasa, head of the PRC.
Thank you, Nina. Welcome, everyone. It's fantastic that we finally are here. And unfortunately, as Nina said, we are not joined together, but we are all joined digital. Palliative care is given much more attention in the public domain, and we have seen that the last couple of years. But we need more. We need more and better integration of palliative care into cancer care. More research to support clinical practice, research that can be applied now because the patients needs it. More basic research to understand the basic mechanisms, not only biology, but also sociology. More collaboration across boundaries, geographical and healthcare researchers. More from you and more of you. You are the core improvements in cancer care. PRC are here to facilitate. We are making fresh ski tracks. As you see, ski tracks are fresh and newly made here in Oslo this morning. And this symbolizes that we need to make 2 new tracks in order to improve research and palliative care in general. We are mostly digital, as we have already said. Next time, however, we are planning a big physical meeting. More about that later during this PRC seminar. We are streaming live from Oslo, and a warm thank to the Norwegian Cancer Society, who's actually making this possible for us. We have 360, Nina, 360 registered participants. That's more than ever. And they're coming from more than 40 countries around the world, such as Nepal, Nigeria, Zambia, Japan, Canada, US, Ireland, Sweden, Moldova, Egypt, Paraguay, Spain, France, Australia, etc., etc. I believe that we have an exciting program, and I hope that all of you will enjoy and like it. I will give a specific and warm thank to the scientific committee, including David Blom, Mary Fallon, Evelyn Køyup, Chris Fishers, Per Sjøgren, Tonje Lundeby, and myself. We received a high number of abstracts this year with very high quality, but only 6 abstracts with the highest score were found or we had placed to present here during the seminar. but the others will be presented digitally in the program. But next time, the plan is to have more presentation based upon submitted abstracts. So before I round it up, some practical information. Use the chat function and the right to ask the presenters for questions. So be active, and we will try to make it as lively as possible. Some of the other submitted abstracts, as I said, they will be posted on our website very soon. A recording of the seminar will be available afterwards on the Norwegian Cancer Society's YouTube channel. And finally, PRC has a Facebook page where you can post news and events. So now I hand over to the Norwegian Cancer Society, Jakob Conradi.
Thank you, Stein. And on behalf of the Norwegian Cancer Society, I'm proud to say welcome to this 11th International Seminar for the European Palliative Care Research Center in our own science center here in the middle of the old town of Oslo. And from the program, I can tell that you have 2 exciting days ahead with so many pressing and required topics. The fact that you come together and share knowledge is also necessary. It's so necessary, and as we say, sharing is caring. Or as we say here in our science center, the spread of knowledge stops the spread of cancer. And the promising results of research from all over the world brings us forward, and by sharing, the future looks even brighter. Our great Norwegian writer, Tarjei Vesaas, he said that since each man or woman is an island, we need to build bridges, lots of bridges. And as you know, history shows that our health services originally have been organized around doctors and specific diagnoses and lacked the focus on patient needs and life quality. Now we know for a fact that given the right palliative care and being able to live a life as good as possible, even though we have been given a sort of expiration date, we live longer and better. We know how important it is to bring patients' own competence in focus, asking them the important question, what do you need? And do you understand what lies ahead? Patient-centered focus is a part of the treatment and especially important in palliative care. And what about the people around the patients, like relatives and next of kins? We need to give them an assurance and relief that their loved ones are being treated in the best way possible. That improves their own life quality. Our demographics, of course, are changing. People live longer, and as they get older, for sure, than with several diseases. And cancer is probably one of them, but not the only one. And this tells us we have to see the whole picture, to see the patient's need and not the diagnosis. We're so proud and thankful of the Norwegian palliative research environment. They have brought to our attention many urgent findings. And one is the importance of bringing the palliative competence and understanding integrated in the whole cancer treatment process. And also how important it is to share knowledge and make sure new knowledge is rapidly implemented into clinical practice. We're so glad and impressed on how you all focus on the importance of international collaboration, building bridges, and sharing important research on such an essential area. I wish you all the best and hope you'll have 2 fantastic and exciting days together. And let me conclude my greeting with what I find crucial to bring quality into life, and hopefully scientifically true. With Nat King Cole's own words, the greatest thing you'll ever learn is just to love and be loved in return.
This is really hard to follow up on. My name is Marianne Hjelmstad. I'm a senior researcher at PRC and work as a researcher also at the Palliative Care Unit at Oslo University Hospital. Thank you for inviting me to share some thoughts and recommendations with you regarding commercial and social determinants in palliative care. And my presentation is based on a talk, on a paper, or a chapter actually, that we have recently submitted. First, I will just briefly ask you to look at the WHO definitions of palliative care. In 1990, the definition emphasized the active approach of palliative care for symptom control in patients with progressive, far advanced disease and limited expectancy. However, from 2002 and onwards, there were continuous recommendations in these definitions that palliative care should be delivered from early on in the disease trajectory, regardless of treatment intention and disease. And this was actually reinforced by the 2014 World Health Assembly resolution, urging national authorities to improve access and develop palliative care as a core component of health systems. The holy grail of cancer care is the delivery of patient-centered care. And this contains a combination of patient and tumor-centered care, and these are approaches that we need. This contains the delivery of patient-centered care alongside anti-cancer care, focusing on the patient with the disease. And systematic patient-reported outcome measures should be crucial in any setting. And there is substantial documentation that this works. It leads to improved symptom management, anxiety, better quality of life, and a number of other patient-centered outcomes. And this is explicitly recommended from major international stakeholders. I have to devote a few words to the two paradoxes, the two largest paradoxes on the opioid crisis. This is a iatrogenic opioid epidemic, most pronounced in the US, but also prevalent in Europe. The extension of opioid prescriptions to a number of conditions has led to the diversion of drugs, which is illegal distribution or abuse of prescription drugs, and has led to soaring numbers of deaths, especially in the US. In 2019, there were more than 70,000 overdose deaths, up more than 4% from the year before. At the same time, we know that there is insufficient pain management, poor accessibility and availability in many middle and low income countries. However, there is a second paradox on this, related to the effect of regulatory interventions to curb this epidemic. A recent register study presented in the JCO comments on more than 270,000 patient records in patients with poor prognosis cancer who died during a 10-year period. They found a 34% reduction in opioid prescription fills, and that is one or more prescription per person who died. A 50% reduction in long-acting opioid prescription fills, and a 38% reduction in the total dose of opioids filled. This was coupled with a 50% increase in the proportion of residents with one or more emergency room visits near the end of life. This gives reason to think. Commercial determinants of health. When I think about this, I tend to think on negative things following a determinant, the commercial aspect. However, it's important to look at the bright side as well. We know that the pharmaceutical industry and the technological development have led to improved cure rates and prolonged survival for millions of people for many, many years. And their continuous drive for new cutting-edge methods and combinations still promote hope. We know that we have poor prognosis cancers for which the advances in treatment have not moved much during the last decades. However, the quality of all this treatment would have been substantially better and more effective if it had been integrated with a palliative care, patient-centered approach. We know that there is extended use of anti-cancer treatment in advanced stage cancer, and a French study in more than 2,000 patients patients showed that 20% of the patients received chemotherapy in the last 4 weeks of life. They also showed more intensive treatment, and we know there are more ER admissions, hospitalizations, depriving patients from time at home with their relatives. And are all the sophisticated technological examinations at end of life necessary? On this background, we were asked to write a short chapter on commercial determinants in palliative care that is to be published in a special issue of EuroHealth, a quarterly periodical by the European Observatory of Health System and Policies. And we were asked to focus on commercial and social determinants in palliative care. We got a very short notice, so to say, so we started on surveying the literature, but then we decided to do a short survey, to develop a survey for the purpose of this particular study, and sent it out to national and international collaborators. Our inclusion criteria for respondents were that they should have vast clinical experience, plus experience from research and management. We ended up with 24 open-ended questions concerning both positive and negative aspects of determinants, and the influence and consequences of commercial and social determinants as perceived by our respondents. It's good with friends, international and nationally. We got an 83% response rate, and the majority of the respondents pointed to determinants in different ways. Most often, the negative influence by the pharma industry was mentioned, economic determinants, political and regulatory determinants, professional. We have to acknowledge that we have a huge potential for improvement among ourselves, and the public and societal levels. We categorize the answers in 2 positive groups and 4 negative groups. And I'll start with the 2 positive groups. And there are a lot of responses, so I'll just guide you very briefly through this. The first category relates to substantial advances in the cancer therapies and the pivotal role played by the pharmaceutical industry. Higher cure rates, extended life expectancy, development of antiemetics, analgesics, antidepressants, etc., to improve symptom management. However, we should not forget that many of these also gives a much higher potential for continuing anti-cancer treatment. It's fair to say, I guess, that opioids are available worldwide, although with a huge variability, both in access and availability. Then there are the policy regulations. There has been a strong enforcement of marketing regulations in the last decades, and privately run non-profit services contribute to better care and research, also in palliative care. Then the first 2 negative groups, and the first is related to the CDO ages, how they shape today's anti-cancer treatment and influence cancer care. And this is predominantly related to economic power and the resources that permits extensive marketing, constant promotion of new expensive drugs, constantly promoting new methods and better and more efficient, in relation to the deliberate underscoring that these apply only to small subgroups of patients. And the patent protection issue that delays bioequivalent products, and they make new ones slightly altered to new, continuing or embarking on a new patent. Then there is the steadily growing and dominating focus on cure. And this is actually also related to a gradual medicalization of society. Social issues, you know, the fluctuations of life, becoming medical issues. And there general marketing, that's the important goal is to stay young and healthy forever. Most cancers and other diseases can be cured, and this is actually a bait for the medical, governmental, public, and private funding. And there is a neglect of the negative consequences and costs of anti-cancer therapy at end of life. And then the commercial interests prevent implementation of patient-centered palliative care because of the dominant focus on anti-tumor care and new drugs and technologies and cure. And death and dying attract little attention compared to anti-cancer treatment. It's not as appealing. which again leads to palliative care and patient-centered care occurring too late. And there is a disproportionate focus, interest, and cost allocation between tumor-centered care and patient-centered care. And importantly, palliative care consultations that may often be necessary during pharmaceutical trials are not reimbursed because they were not defined as such in the study protocols. And then there is a common perception that any physician and oncologist can provide specialized palliative care and patient-centered care. Again, the referral to specialized services occur too late. And there is an unfavorable marketing of anti-cancer drugs. Present regulations of industry-driven marketing remain inadequate. And there is a constant strive to expand the indication for a number of drugs, which generates income. And there is an extensive marketing of expensive analgesics with no superior effects compared to morphine, a huge problem, especially in middle and in low-income countries. So I have a limited time, and we came up with a lot of recommendations that I don't have time to present here. But sometimes Stein is in the creative corner, so he thought we needed a figure, and Tonje sketched one, and we filled it with sort of a synthesis of our recommendations, top down and bottom up. There is important to implement strong intensive, and the target has to be policymakers, WHO, EU, national authorities, and these relate to laws, regulations, financial issues, incentivizing actions, public dissemination strategies. Palliative care and patient-centered care has to be included and integrated in all parts of healthcare. This relates to healthcare target institutions, public, private, medical technology, universities, and professional organizations. And then on top, we have the most important recipients, the patients and families. Patient-reported outcome measures, patient-reported experiences, and patients' wishes, shared decision-making, treat symptoms, improve functions, and quality of life. So I will end my talk with a special thanks to those responding to our survey outside of Oslo. Thank you for your attention.
Thank you, Marianne. We have also an important person with us here who is overseeing the chat. That is Olav Dajani. So I wonder, do we have any questions now, or?
Not yet. So
Not yet.
Encourage.
Well, okay. So then I'll, Marianne, ask you a short question. It might be simple or it might be complicated. Because you are saying on the one side, we have seen a major breakthrough in the anti-cancer treatment the last decade, with improved cure rates and even more improved survival, for example, for malignant melanoma, for non-small cell lung cancer. And on the other side, you're saying that there are quite a few negative effects here. So how do you foresee, number one, how should palliative and patient-centered care collaborate with the oncologists? And how should palliative care movement collaborate with medical industry in order to see a change in the future?
Well, that was actually two questions.
Yeah,
Two big questions.
Yeah, so you can, since time is running fast, the audience can also think about them, but maybe you can give an answer to one of them, and you can actually choose which one.
Well, I guess I can talk or try to respond to both. I think to inform and to influence policy, we have to start at the bottom of the ladder, and we have to be forcing someone to do something never works well. So we have to try to collaborate with institutions. We have to be present. We have to try to make them understand the importance of the dual perspective, tumor-centered care and patient-centered care, to the profit for all, actually. I think that's important, and that has to do with regulations, and it has to do with economy in intensivizing some of these actions. And then in relation to more clinical practical work, there is sort of a circular collaboration, as I see it, between step 2 and step 3 of the ladder. The patients, the families who are the customers, and the providers who are the sellers. And we have a lot to learn.
Okay, great. So we are foreseeing that this 3-step ladder will be just as much used as the 3-step pain ladder.
Well, we'll see. I've heard a story that the WHO pain ladder was drawn on a napkin. This was drawn on the kitchen table, so
Yeah,
there is hope.
Very close. Olav, do we have any other chats?
No,
Okay. Then it's I'll just tell the audience from all over the world, please use the chat and give us input and give us questions. So for the time being, thank you, Marianne. And now we move on to the next talk. That's Bart de Hey. He combines his internal medicine residency with research at the University Medical Center in Groningen in the Netherlands. And I hope that he's with us live online. And he will talk about organization of a flash mob study regarding palliative care needs of Dutch hospitalized patients. So Bart, are you there? At least I see his slide, and there I see Bart. But do you hear me? There might be some technical issues, so we'll sit down and relax and take a drink while we are waiting.
I welcome you all to the PRC Congress in Aarhus in 2022. The PRC is a palliative care research center situated in Oslo and led by Professor Stein Kasa.
We are very much looking forward to have this conference placed here in Aarhus and to meet again after years of online conferences.
The seminar focuses on collaboration, and we're bringing in researchers from all over the globe to enhance collaboration in palliative care research.
The conference is for everyone interested and working with palliative care, for all professionals, researchers, professionals working together with the patients in palliative care.
Aarhus University Hospital is one of the largest and most modern hospitals in Northern Europe, and we have more than 9,000 team members.
The conference will be held here in the very center of Aarhus, next to the famous art museum, the town hall, the old town, and outside Aarhus you'll find sea, the woods and the harbor.
Aarhus is a wonderful city, and I think it will be a great experience to keep the Congress in this wonderful environment and to have a great time here.
Today Aarhus is a very young city with very many students living here. It's a vibrant, lively city with plenty of bars and restaurants and a very cozy atmosphere.
I'm always very, very excited about these congresses, and I know there's always new information, new studies, and it's also an opportunity to meet new people and especially young researchers within the field.
I look forward to meeting colleagues from all over the world to hear about new results in palliative care research, but also to share our results here from Aarhus University Hospital.
We are very much looking forward to seeing you at the PRC conference here in Aarhus.
Friends in Aarhus, we will come back to you later, and I know that you are online, so this was a pre-seeing of your very nice film. So Bart, now, do you hear me now? And very much welcome to
Thank you
talk
very
about
much.
your study.
Yes. Hello. I would like to begin by thanking the organization for the invitation to talk with you about the flash mob studies. And it was even snowing a bit this morning here in the Netherlands. So I almost felt after seeing the ski tracks if I was live present in Norway. Thank you for inviting me. My name is Bart de Heij. I'm a resident in medical oncology and PhD candidate at the University Medical Center of Groningen in the Netherlands. And this talk will mainly be about the organization and experiences of conducting a flash mob study regarding palliative care needs of Dutch hospitalized patients. I have no potential conflict of interest to declare. And the presentation is roughly divided by starting about the history and characteristic of flash mob studies, then the organization of a flash mob study regarding palliative care needs, and especially our own experiences doing this. Let's start by pointing out some of the problems of traditional research processes. Ideas for research topics or clinical relevant questions arise at the kitchen table while working at the wards or during a congress like this one. And then at home you can work out the methods, think about the needed researchers, funding, etc. And as an enthusiastic researcher, as I guess we all are, you want answers for your questions as soon as possible. But the time lag from the conception of your idea until the actual publication or even implementation can take many years. Furthermore, the methods for data collection can be complex, extensive, and most of the times you will need experienced researcher to collect the data over a longer time period. So overall, the traditional research process can be time-consuming, and I would like to say, well, can a new approach like a flash mob study, can that be the solution for this time-consuming period for traditional research? So what is a flash mob study actually? When I was looking for an accurate definition of flash mob, I first stumbled upon this one where it stated that a group of people who rapidly assemble, perform an unusually and seemingly pointless act, and then quickly disperse. Not quite an advertisement for a serious study. But that, of course, comes because of it points to the dozens of dance acts one can find on the social media where groups of people suddenly start dancing or singing together at stations or hospitals with the Jerusalem song, what was very popular last year, and leaving unknown people, bystanders, leaving them in total amazement. But regarding the more serious flash mob, the definition can be better described as a group of people who are summoned by email, text message, social media to a designated location at a specified time to perform an indicated action before dispersing. So that's the general idea of a flash mob. In the research field, this really is a novel approach with up to now less than 10 published studies using the official flash mob method. And the first publication using this was in 2013 in Chest with a study evaluating the accuracy of recorded respiratory rates in inpatients. And this was a single-day resident-led prospective study, observational of recorded versus directly observed vital signs at 6 large tertiary care centers across the United States. And in this study, internal medicine chief residents from 6 academic centers established a collaborative network that obtained institutional review board approval at each center. They developed a research protocol and engaged and trained other residents in the conduct of this large-scale clinical study. And after that, it was a bit quiet, but then in 2017, the next flash mob study came out. And well, if you were a little bit in doubt until now, this should convince you. As you can see, these authors, just like me, they also believe in the power of flash mob research. That's the title. And the topic of this research was more, they looked into the capillary refill time, a clinical test used to evaluate the circulatory status of patients. And in this study, Physicians in the Netherlands were recruited by using word of mouth referrals, conventional media, and social media to participate in a nationwide single-day 9 to 5 multi-center study to evaluate this capillary refill time. And this, in the end, resulted in a total of more than 400, almost 450 investigators in nearly 40 Dutch hospitals and enrolled more than 1,700 patients in just one day from 9 to 5. The author stated that the flash mob method proved a valuable instrument to investigate a relatively simple clinical question in an inexpensive, quick, and reliable manner. And also 3 other studies to complete this image that used the flash mob method until now was a study about quantity and quality of sleep in hospitalized patients, the identification of acute coronary syndrome by general practitioners, and also the use of intravenous immunoglobulin in immune thrombocytopenia. Then I would like to walk you through some of the main characteristics of the flash mob studies. And well, it's divided into 2 parts, you can say, to start with the flash, the study itself. Important characteristic of it is that the research question needs to be simple and attractive in order to gain attention and attract sufficient data collectors, which is key in this study concept. The design, that's actually should be cross-sectional, and if follow-up would be required, it needs to be very short, as the recruitment period itself is also very short, mostly 1 day, and it can go up to 2 weeks. But mostly 1 day. It is very important that the informed consent procedure is very brief and easy to understand, so that the burden for patients can be very low. There needs to be foolproof research material because the lack of experience of some of the data collectors, and you should only collect limited data that is promptly available for analysis, so that the analysis time can be very short. And therefore also the cost can be very low with this sort of studies. Then we go to the mob, which means like a group of people. And of course, very important that you have some motivated team members. That is a core research team that is responsible for the research question, the design, the study protocol, development of research forms, the ethic approval, and also, of course, the construction of the database. The core team can develop the strategy to reach potential participants by their own networks, or creating new one by, for example, by using membership lists of professional organizations, congresses, websites, or the social media. And well, this research team, of course, also performs the analysis to disseminate the results. Very important in the flash mob study are the local ambassadors. They are essential to the success of this study. They are key stakeholders or influencers in the participating organizations who facilitate, coordinate the study locally. And they also mobilize the mob or the data collectors who are performing the assessments in the patients themselves. Then some advantages of flash mob research. Those are multiple, with, well, the main being the shortening of the running time of the study. For example, that first study I mentioned about the vital signs organized by residents, that took only 90 days from inception till submission of the article. And then, well, the flash mob, it has a fun, there's a fun character to it. That attracts data collector that traditionally would not participate in research. So as a consequence, the risk for inclusion bias is lower, and it may therefore also yield more generalizable findings. And flash mob research aims to attract a lot of attention to gain the interest of potential data collectors, and create a hype generally attracts the attention from mainstream media, social media, which is very important, and hence that the flash mob study will facilitate also popularization of science. Now, having read about those flash mob studies and its advantages, it was during an informal dinner pre-corona time with our palliative care team members of the University Medical Center of Groningen that the topic of palliative care needs of admitted patients came up. To give you a little background why we were talking about this, it's not really clear how many of the admitted patients have a life-limiting illness. And during a questionnaire which was done in 2017 in the Netherlands, came out that the palliative care team, so specialized palliative team members, were involved in less than 1% of the admitted patients. And it was not exactly known how many of those patients actually receive palliative care as well by specialized practitioners or general doctors and caregivers. So with this background, we aim to investigate how many patients with a probable limited life expectancy were hospitalized and whether a palliative care team was involved or involvement was considered desirable. And first, when we started, we thought we'll just do this in our own hospital, and that would be really fun to do. But then other peoples from our networks, they heard of the idea and were very motivated and enthusiastic to cooperate. So in the end, we ended up with a lot of hospitals also want to join us. And here's a little situation of the Netherlands where you have about roughly 100 hospitals. So we invited all of those hospitals to join us in this flash mob study. I think it's very important when you want to perform a flash mob study. The preparation is very important, as you cannot change anything anymore on the day itself. It's the day itself, everything needs to go flawless. So while preparing for the flash mob study, you need to have a local ambassador for each hospital or each organization. You need already all the approvals from the Medical Research Ethics Committee. You have to make some data transfer agreements because, well, there are other organizations involved. What will happen with their data? How do you, how would you do that together? And it needs to be all done before you start. Then, of course, how will you collect the data? Which software will you use? Who are the collectors? How can you reach them? A lot of preparation before the moment itself. So to give you a little timeline on how we did this with this study, it started a bit in September when we made the application for the Medical Research Ethics Committee and made a data management plan to see what sort of data we would use. Then 2 months later, this was approved by the Medical Ethics Board of UMCG in Groningen. And then we started drafting the data transfer agreements with all the hospital, which was, that's quite time consuming, but very important. And then actually we wanted to start. As I said, the time lag is long, but not in flash mob study. So we were ready to start for the day itself. And then something called COVID came by. But it gave us time to review some of the data transfer agreements and ethical board improvements in the participating hospitals. And then the day itself, in the spring, in April 2021, we had our flash mob study regarding palliative care needs. So on April the 16th, the short questionnaires were filled out by nurses and doctors about the admitted patients in Dutch hospitals of that day. And there were only a few questions, like I said, that was about the surprise question. So would a nurse or doctor be surprised if their patient would die in the next 12 months? It was about life expectancy of less than 3 months and the involvement of palliative care teams, and only some patient characteristics to keep it very short. And I think one of the keys of flash mob studies, it has to be, you have to make fun also. It has to be, or you have to arouse enthusiasm. And with a little wink, we used the surprise question. So I don't know whether it's known in entire Europe. I guess it is. But we gave to all the participants, to the mob, we gave all the surprise eggs from Kinder, which was received with a lot of enthusiasm. The day itself, social media is important to motivate, to strengthen all the people who are cooperating. So there were a lot of tweets, Facebook, all was used to keep everybody involved. So what were the experiences? Like I said, there was a lot of enthusiasm from the participating researchers already before we began, but also during the day itself. It was a lot of fun to be part of this as one of the research team. There was a lot of support. You cannot, for us as a research team, because you cannot go without consultants, privacy, research consultants, people from the software, a lot of people preparing this for you and being prepared to do whatever it takes on the day itself to make everything go smoothly. And also the data management software we used, that was luckily it held, and that was of course also because we tested often before for the big amount of people that had to fill in the electronic case report forms. To wrap it up with some practical advice, like I said, and don't forget, preparation is key, especially in a small group, so you can make a lot of progress. Make sure, because if you're working with other organizations, that you make clear data agreements so there's not any inconvenience later, and use a playful setup or hot topic to gain more interest. So we are actually quite enthusiastic about the use of the flash mob study, and we hope that we can build on our flash mob here in the Netherlands, and might interest some of you for a pan-European study later after we can present the results of our own flash mob study. It would be really nice to make this go bigger and bigger. So this may be the first step for that. So concluding about flash mob studies, a small research group can inspire many data collectors, especially the ones who are normally not involved in normal science. And it can also answer especially clinical relevant questions in a short time period. I would like to end by thanking the participating hospitals in the Netherlands, and a special thanks to the members of our research team, and of course to you as a listener today to this presentation. So I hope there's some time for questions left.
Bart, thanks for an excellent presentation, and at least for me, it gave me lots of second thoughts. Very interesting methodology. We might have some questions on the chat.
Yes, we have one question here. What is the most challenging aspect of conducting a flash mob study from your experience, and how could we solve it?
So Bart, did you hear the question?
I think one of the most, it's very important in the preparation that you make clear agreements with everyone involved. Especially the bigger the flash mob can be, the more organizations are involved. I think it's very important that nothing goes wrong on the day itself. You cannot change anything anymore about the study on the day when you collect the data. So be sure that your software works. Be sure that the agreements between groups are clear. I think that's that especially about the data agreement forms that goes. It's very time consuming, because what happens with the data from another hospital? Can we share that easily together? That's the big advantage is that you have a big group. A lot of hospitals are involved, but that also means you have a responsibility for the data. And also you want, of course, and that's not only negatively as in that what will they do with your data, but that you also want to give back the data to the hospitals itself, because they put so much effort in it. I hope that answers your question a bit.
Thank you. I think we need to move on. We are a little bit late in the program, but that's not your fault. We had some technical issues. And I think you have raised, as I said, I hope for many others also, how can we use this methodology maybe to answer some of the questions that Marianne also raised in her first talk about why or to which degree is palliative care integrated into hospital care, primary care, cancer care as such. So
Yeah.
So let's. Do you think that there are any particular research questions? Try to give a short answer to that. Where this methodology specifically apply to?
Well, I think the main thing is it's mostly for clinical relevant questions. So if you are just as now as if you see some things passing during the Congress and you think, I would like to know that, or is that also the case in my hospital, in my country? If questions like that needs only a little bit of data and you want big groups to answer it, then that would be key for this. And that's also why I showed the other flash mob studies as well. They were all clinically relevant, brought in front by the healthcare practitioners themselves.
And thanks for this excellent presentation. And if you keep online now for the next day and tomorrow, maybe you can come up with some consideration during other presentations and maybe give some thoughts about, well, hey, this study could have been a flash mob study. So
yes, thank you. I will.
I'm challenging you.
Thank you very much, and I hope you can challenge also the other listeners to come up with some of those subjects concerning palliative care. Would be really nice.
Great, thank you. And I will go for a 10-minute break, and we will hear more about the Aarhus movie and look at it and listen to it. So find yourself some coffee, something to eat, something to drink, and we'll soon be back.
I welcome you all to the PRC Congress in Aarhus in 2022. The PRC is a palliative care research center situated in Oslo and led by Professor Stein Kasa.
We are very much looking forward to have this conference placed here in Aarhus and to meet again after years of online conferences.
The seminar focuses on collaboration, and we're bringing in researchers from all over the globe to enhance collaboration in palliative care research.
The conference is for everyone interested and working with palliative care, for all professionals, researchers, professionals working together with the patients in palliative care.
Aarhus University Hospital is one of the largest and most modern hospitals in Northern Europe, and we have more than 9,000 team members.
The conference will be held here in the very center of Aarhus, next to the famous art museum, the town hall, the old town, and outside Aarhus you'll find sea, the woods and the harbor.
Aarhus is a wonderful city, and I think it will be a great experience to keep the Congress in this wonderful environment and to have a great time here.
Today, Aarhus is a very young city with very many students living here. It's a vibrant, lively city with plenty of bars and restaurants and a very cozy atmosphere.
I'm always very, very excited about these congresses, and I know there's always new information, new studies, and it's also an opportunity to meet new people and especially young researchers within the field.
I look forward to meeting colleagues from all over the world to hear about new results in palliative care research, but also to share our results here from Aarhus University Hospital.
We are very much looking forward to seeing you at the PRC conference here in Aarhus.
Welcome back from a short break. We're now into the second part of the first session. And this part is based upon submitted abstracts. And as I said during the introduction of the seminar, that we have selected the abstract based upon ranking from the scientific committee. And these are the top ranked abstracts. We have 10 minutes per presentation at the maximum, including questions. So I hope that the presenters stick to 8 or 9 minutes, so we have some time for questions. So the first out is Olav Yri. He is an oncologist and palliative care physician in Oslo, and he will present whole brain radiotherapy for brain metastasis. Should we stop using it? So the word is yours, Olav.
Thank you. Thank you for the opportunity to present this talk on whole brain radiotherapy for brain metastasis, where I ask the question to you, should we stop using it after more than 80 years of practice? And the question is based on reflections from a prospective cohort study that we are now starting to analyze. Radiotherapy is one of the most frequently applied treatment methods for patients with brain metastasis. And there are two main principal ways of distributing radiotherapy to the brain. Illustrated here on the right side is the stereotactic radiosurgery, where the main principle is to focus the radiotherapy with a high dose to the brain tumors only, and sparing the healthy brain from radiation. On the other hand, the whole brain radiotherapy, as you see here on the left, the whole brain gets the same homogeneous dose, so that the healthy brain also is exposed to the same dose as the brain lesions. There are several ways of doing this in practical terms, so-called treatment regimens or dosing regimens. The most frequent applied regimen is the 3 gray times 10, and this means that you give 10 treatments with a dose of 3 gray per treatment, and you give 1 treatment each day. So you have 10 days of treatment, which in practical terms means at least 2 weeks of treatment for the patients. Other regimens may be 4 gray times 5, in which you increase the daily dose, but you lower the times of treatments. So we have 5 treatments instead of 10. Or you can lower the dose for each treatment and then increase the number of treatments, as in 2.5 grays times 15. But there are also several other regimes that can be applied. A few words on our prospective cohort study, which we have conducted over the several last years. It's called Brain Metastasis in Norway. In this study, we included patients with solid cancers that were newly diagnosed with brain metastasis. And we collected data every 3 months, clinical data every 3 months, and then PROM data monthly using standardized questionnaires. And from November 2017 until March this year, we included 917 patients. So for this talk, I will focus on the proportion of patients in our study that received whole brain radiotherapy as their initial treatment for the brain metastasis. And this was about 40% of the patients. And when we look at survival data in these patients, almost half, or 46% of them, died within 3 months after brain metastasis diagnosis. And this is from diagnosis, not after treatment. So this survival time also includes the treatment time. And nearly 3/4 of the patients died within 6 months. But then more than 8% lived more than 12 months, and also some patients lived more than 2 years and are still alive and a part of the study. So clearly, this patient group is very heterogeneous. And this made us ask again the question, should we use this kind of therapy on all these patients, or should we be more selective? And I guess the answer is kind of given. So then we wanted to look into, can we identify up front which patients are likely to have a short survival expectancy and which are expected to have a longer survival expectancy, and thereby choosing more accurately which patients which may benefit from this treatment. And the factors that we have found so far is to be associated with prolonged survival are ECOG status, which should be a good, a lower age and quite low actually, breast cancer as primary cancer, and non-progressive extracranial disease, which means that you have control of your liver metastasis or your lung metastasis, or that you don't have extracranial metastasis at all. Now, these factors are not novel. They are known from before, but we confirm them. And we confirm also that even if we know about them, we still use this treatment on patients having adverse prognostic factors. More interestingly, we also find that patients living less than 6 months reported poorer baseline scores on several PROMS domains, including quality of life, physical functioning, and several physical symptoms. So then it was pertinent to ask the question, should you treat patients with whole brain radiotherapy? And I'll start with a quote from a patient blog that I accidentally came across yesterday when I was doing my Google research for this talk. And I'll quote her, "It's been 2 weeks since my last round of radiation and the fatigue is extreme. I'm so tired. I just keep reminding myself that it's over. I've had a hard month." And she had just finished 3 weeks of whole brain radiotherapy. And this was a woman, quite young. She had breast cancer, she had controlled extracranial disease, and she had a good performance status. So she was on the best scale, if you like, according to those factors I just showed you. So just imagine a male, 80 years old, lung cancer, uncontrolled liver metastasis, ECOG status 2 or 3. How do you think he will feel after this month? So then, should we treat patients with whole brain radiotherapy? And my answer at this time is most likely only if the patient may benefit from obtaining intracranial tumor control, and that will be patients that have stable extracranial disease or have the possibility to obtain so with further systemic treatments. They should have a good performance status, at least 0 or 1, where ECOG 2 status might be questionable. Age is a factor to be considered, but age is a very difficult factor to consider. In addition, the physician and the patient should together consider the possible cognitive and other potential long-term side effects of the treatment, and stereotactic radiotherapy should not be an option. Then you can consider whole brain radiotherapy, in my opinion now. Interestingly, we may also apply patient-reported symptom burden and health-related quality of life as an additional prognostic information, and we are now looking more into this. So, to conclude, on my behalf and perhaps your behalf, should we stop using whole brain radiotherapy? I think it's a dual answer. It's a yes for a high proportion of patients that are offered whole brain radiotherapy today, as these patients will most likely benefit more from optimal palliative care alone. And it's a doubtful no for a carefully selected minority of patients who are not candidates for other intracranial treatments. Thank you.
Thank you, Olav. Do we have any questions in the chat?
Not so far, only just for thanks for the previous talks and discussion. It seems there's a little lag in the chat, so people should follow the chat, I guess, too.
Yeah, people are probably not that used to it, but so you guys all over, you have to speed up. You have to come up with the questions during and just after the presentation.
Well, I have one question now from...
You have one?
Yeah.
Okay, fantastic.
Okay, it's from Ernolf Paulsen.
I'm sorry, I can't hear you now.
Do you hear me now?
Yes.
Olof, yeah, okay. One question. Did you also include patients not receiving radiotherapy for comparison?
We included all patients admitted to us or diagnosed with brain metastasis, regardless of intended therapy. So patients with the surgery upfront, stereotactic radiosurgery, palliative care alone, systemic therapies, all kind of patients.
Okay, we have one more. Did the data set include meningeal carcinomatosis patients?
Yes.
Okay, that's so far.
Okay, Olav, I have some sort of questions or comments. One is we're looking forward to get all the analysis, but given that, sorry, that your data stands up and that you are able to identify subgroups who should or should not receive whole brain radiation, how are you going to implement that into cancer care when you, because this has been a debate for 10 years or so?
Yeah, that's the everlasting good question, because these are not actually new findings, I'll say. But now we can confirm findings in a rather big material. So I think it's important to inform our colleagues about our findings and start doing it ourselves in our own institutions that have participated in the study, and start there.
Okay, great. Maybe you could have done a flash mob study and asked about how people around Europe are actually performing when they're having patients with brain metastasis. Let's just have that question hanging around. So thanks a lot. We need to move on. The next presentation is from Holland, from Janneke van Rooij from Tilburg University in the Netherlands. And she will talk about quality of life and quality of care as experienced by physicians and their relatives, a multi-center observational cohort study. So, Janneke, you are online.
Hello everyone, I'm Janneke van Rooij. I work at the Netherlands Comprehensive Cancer Organization, and today I'm going to talk to you about my research on quality of life and quality of care as experienced by patients with advanced cancer and their relatives. So in the Netherlands, 1 out of 5 people with cancer has metastasis at time of diagnosis, and annually 38,000 people have metastatic cancer in the Netherlands. And despite medical advances, the survival of these patients is still limited. And palliative care is important for these patients because research has shown that it improves quality of life in patients, but also in their relatives. Up to now, it was unclear which elements of care are important for their quality of life. So the aim of our study was to assess quality of life and quality of care in patients with metastatic cancer and their relatives, and also assess the association of emotional functioning with their experienced quality of care. And because we know that their experiences are related, we also wanted to use a dyadic approach to include the reciprocal nature of these experiences. So we did a prospective multi-center observational study in which 40 hospitals in the Netherlands participated. Patients with metastatic cancer and their relatives were asked to participate in our study between November 2017 and March 2020. Patients and relatives received questionnaires every 3 months via profiles, either online or on paper. And we use clinical data from the Netherlands Cancer Registry, such as the date of diagnosis or primary tumor type. And we use data of a normative population from the LIS panel. And this panel is an online household panel that is representative for the Dutch general population. So we used baseline questionnaires of our study and used descriptive statistics to assess quality of life and quality of care. And we compared quality of life scores to a normative population. And we looked at the association between emotional functioning and experienced quality of care in patients and partners separately, but also simultaneously in a dyadic approach. So in our study, 1,103 patients participated and 831 relatives. half of the patients were female and 61% of the relatives were female. Patients were on average 65 years of age and relatives were somewhat younger. The majority of patients and relatives were medium educated, and about 74 of the relatives in our study were the partner of the patient. The four most prevalent primary tumor types in our study population are shown. So 29% of the patients had lung cancer, 19% had colorectal cancer, 15% had breast cancer, and 12% had prostate cancer. 81% of our patients were diagnosed with their primary tumor type within 5 years prior to the questionnaire. So in this figure, you see that the blue bars are the scores of the patients and in gray the scores of the normative population. And as expected, quality of life of patients was lower compared to the normative population. And this was the case for all quality of life domains of the E-Where2See Quality of Life C30 questionnaire. And in yellow, you see the scores of the relatives. And you can see here that their emotional functioning scores were even lower compared to patients. Compared to patients, relatives were less satisfied with continuity of care and continuity of information regarding care for the patient. And about half of the relatives also reported to have received care for themselves. And these relatives were also less satisfied with the care they had received for themselves compared to patients. So their scores were actually lower compared to patients. So in our separate regression analysis, we found that in patients being more satisfied with care in general and clarity about who their central healthcare professional is was positively associated with their emotional functioning. In relatives, we found that continuity of care and information in care for the patient was positively associated with high emotional functioning. And discussing what is important in care for the patient was negatively associated with high emotional functioning in relatives. So because not all patients had a relative in the study, we only included unique patient-relative couples in our dyadic analysis. And we found that emotional functioning of patients and relatives were positively associated with each other. And in addition to the significant associations we found in our previous analysis, continuity of care for the patient as perceived by relatives was positively associated with high emotional functioning in patients. So in other words, how relatives perceive the continuity of care for patients is positively related to the emotional functioning of patients. To conclude, quality of life is severely affected by metastatic cancer. And surprisingly, the emotional functioning of relatives is even lower compared to patients. Continuity of care for the patient, as perceived by relatives, is related to the emotional functioning of both. Because emotional functioning and care experiences of patients and their relatives are interrelated, a family approach in healthcare may have potential to improve quality of life of both. To thank you for listening, and a special thanks to all patients and relatives who participated in our study, all hospitals who helped conducting the study, and especially thanks to the Europa Foundation who financed the study. Thank you for listening, and for more information, please contact me.
Thank you, Janneke. This was a pre-recorded presentation, but I hope that you are online. Olav, do we have any questions in the chat?
Not so far.
Not yet. It might come up. But Janneke, I'll ask you the difficult question. From the clinics, do we have any take-home messages here which we can take back to the clinic with regard to improving our practice?
Yes, I think one of the key messages from this presentation is that we shouldn't forget about the relatives because they are suffering as well. So I think that's one very important point to take away from this presentation. And besides that, it's also important to not only take into account the well-being of the relative, but also the interaction that might play a part in their well-being. So how the relative may affect the patient and vice versa. That's also a very important message to take away, I think.
so do you think in practical clinic, so you're saying actually two things in my mind, or you're saying several things. One is that we should involve the family in the care process.
Yeah.
But we should also have an eye to the family as a separate unit in addition to it.
Yes.
I want, maybe we could ask the question around and people can think about it. Do we systematically assess family members' needs and constraints during palliative care clinical practice? To my experience, at least where I have been working the last 25 years, we are doing it, but not maybe not systematically. So what's your experience?
Yes, that's also what I found in the literature, that it's not systematically or monitored in clinical practice. So I think there should be more attention for the well-being of relatives, and then systematically and more frequently than it's currently being done in practice. Yeah, so I do recognize your point. Yeah.
Janneke, I think we need to move on. Thanks a lot for an excellent presentation. It's good to have you on board. So we'll move on. The next presentation is also pre-recorded. It's by Kyle Fitzgibbon. The topic is Emotion and Symptom-Focused Engagement, EASE, a multi-site RCT.
Good morning, everyone. My name is Kyle Fitzgibbon, and I'm coming to you from the Department of Supportive Care at the Princess Margaret Cancer Centre in Toronto, Canada. I'm speaking to you today about our multi-center randomized controlled trial for patients with acute leukemia called Emotion and Symptom-Focused Engagement, or EASE. Quick acknowledgement of our study team. Our principal investigators are Drs. Gary Roden and Camilla Zimmerman from Princess Margaret. As well, you can see the rest of our study team listed here. So traumatic stress is defined as the response to a traumatic event that includes the exposure to actual or perceived death as defined by the DSM-5. And it includes 4 distinct symptom clusters. And these are re-experiencing, avoidance, alteration in cognition and mood, and arousal. There are 2 diagnoses under traumatic stress. The first is acute stress disorder, or ASD, and the second is post-traumatic stress disorder, or PTSD. And traumatic stress is an intense and unstable emotional state characterized by intrusive and distressing thoughts, persistent negative mood, difficulty remembering, and active efforts to avoid, irritability, numbness, and hyperarousal. There's a severe impact of acute stress disorder, or ASD, on the quality of life, risk for suicide, health, mortality, and there is a high risk for the subsequent development of PTSD. Unfortunately, there's a scarcity of research on traumatic stress in oncology, and this is important because the communication of news about diagnosis, progression, or recurrence of advanced cancer could be classified as a traumatic event. We have measured the presence of ASD and PTSD in a substantial number of oncology patients with various cancer types, but mostly in the later course of the illness. There's very little research focused on the early illness trajectory. And this is partially due to the difficulty in recruiting patients and has resulted in a lack of targeted evidence-based interventions. Acute leukemia is the 6th most common cause of cancer death in Canada, and it's a prototypical condition of a traumatic event in oncology. And this is because it's characterized by the rapid onset of symptoms requiring urgent hospitalization and the initiation of intensive treatment that comes with severe physical side effects. This immediate threat to life and substantial physical suffering results in frequent traumatic stress symptoms. There are 2 types of acute leukemia in adults. Acute myeloid leukemia, or AML, accounts for about 80% of adult acute leukemia, and it comes with a median survival of about 11 months. And acute lymphocytic leukemia, or ALL, accounts for most of the remaining 20%, and it has a median survival of about 2 years. So as you can see, at the time of diagnosis of acute leukemia, there is an immediate threat to life. It also comes with substantial toxicity and severe and potentially fatal side effects, including infection, bleeding, major organ toxicity, and multiple other drug-specific side effects from the intensive treatment. Despite this distress, referrals for specialized psychosocial support from palliative care tend to only occur in the final weeks before a patient dies. We conducted a longitudinal observational study at Princess Margaret for patients with acute leukemia, and here's what we found. 37% of our sample met criteria for full or threshold acute stress disorder, and we found that these traumatic stress symptoms persisted or occurred in 55% of the sample over the 3-month follow-up. And this is actually more common than in patients following a major physical trauma. Physical symptoms were more severe than those reported in patients with solid tumors, with 91% of our participants reporting 5 or more concurrent physical symptoms. And these symptoms persisted over the entire follow-up. We also measured a lack of referral to specialized psychosocial and palliative care. Only 14% of our sample were referred to psychiatry or psychology. A measly 3% were referred to palliative care. Importantly, with none of the participants who reported pain as a physical symptom being referred to palliative care. And although a majority of the patients were referred to social work, this was predominantly for practical assistance as opposed to psychosocial support. So this led our team to develop an intervention called Emotion and Symptom-Focused Engagement, or EASE. And EASE consists of 2 components. There's the EASE-PSY component, which is the psychological intervention, and the EASE-PHYS component, which is the physical symptom intervention. EASE-PSY consists of 8-week manualized psychotherapy tailored for patients with acute leukemia to prevent and treat psychological symptoms. And this is predominantly focusing on symptoms of traumatic stress. And this intervention includes supportive counseling and trauma-focused cognitive behavioral therapy, as well as emotional assessment and affect modulation. EASE-PHYS consists of 4-week systematic screening of physical symptoms with triggered referral to palliative care for symptom management for any moderate to severe symptoms. We use an amended version of the Edmonton Symptom Assessment Scale, or the ESAS, for patients with acute leukemia, which we've called the ESAS-AL. And this is administered twice weekly during the 4 weeks that a patient is admitted to hospital. So 4 weeks is a typical length of stay for acute leukemia patients, and that's why this intervention is 4 weeks versus the 8 weeks for the EASE-PSY. And this is based on evidence that early palliative care for individuals with solid tumors improves quality of life and satisfaction with care. Here you can see the ESAS-AL. So these are all of the symptoms, and you can see that a score of 4 or higher on any of the symptoms except for depression, anxiety, and well-being trigger an automatic referral to palliative care. Depression, anxiety, and well-being are used to guide the EASE-PSY therapy sessions, but in and of themselves do not automatically trigger a referral to palliative care. And we found that a score of 4 or higher provides optimal sensitivity and specificity. When a score of 4 or higher is reported, there's an automatic referral to palliative care. Palliative care will meet with the patient within 72 hours and then twice weekly for management of symptoms until the patient's symptoms fall back below the threshold of 4 or the patient is discharged from hospital. When an outpatient, patients can still access palliative care and they may be re-referred if required by their EASE-PSY clinician. And the EASE-PHYS component follows the treatment guidelines of the Ontario Cancer Symptom Management Collaborative. We then conducted a pilot randomized controlled trial of EASE at Princess Margaret a couple of years ago to assess its feasibility. And you can see that we met or exceeded all 3 of our feasibility metrics, which were the completion of 50% or more of our EASE-PSY sessions, completion of 50% or more of ESAS-AL screenings, and having all patients who reported symptoms of moderate to severe having at least 1 meeting with palliative care. So this shows us that EASE is feasible. And despite not being powered to detect statistically significant differences, we did in fact still detect a significant treatment group difference favoring EASE for traumatic stress symptoms at 4 and 12 weeks, as well as pain intensity and interference at 12 weeks. We also measured positive trends for EASE on depression, number, severity, and distress related to physical symptoms, quality of life, satisfaction with care, and attachment security. And these quantitative findings were further supported by qualitative interviews that we conducted with the patients. So this brings us to where we are today with our multi-center randomized controlled trial. So this is an unblinded multi-site phase 3 RCT of EASE plus usual care versus usual care alone. And so this is what we're just in the midst of bringing online now. It just launched at Princess Margaret a couple weeks ago. Our primary outcome is measuring the severity of traumatic stress on the SAS-RQ and physical symptom severity on the MSAS at the 4-week time point. So that's our primary endpoint. And this study is occurring in the Princess Margaret Cancer Centre here in Toronto, Canada, as well as our partners across the province of Ontario, Kingston Health Sciences Centre, Sunnybrook Health Sciences Centre, the Ottawa Hospital, and the Ottawa Hospital Research Institute. Participants will be patients newly diagnosed with acute leukemia who will be recruited and randomized within 10 days of hospital admission for intensive acute leukemia treatment with curative intent. We're looking to randomize 266 participants, 133 in each arm. And this study is a collaboration with the Canadian Cancer Trials Group, the Canadian Institutes of Health Research, and the Canadian Cancer Society. Here's a quick schematic of our study design. So you can see patients here are admitted to hospital. We'll aim to recruit and randomize within the first week. Patients will either be randomized to usual care or to the EASE intervention. For those who are randomized to the EASE intervention, they will receive 8 weeks of the EASE-PSI psychotherapy sessions, as well as 4 weeks of systematic physical symptom screening, with any patients reporting moderate to severe physical symptoms receiving an automatic referral to palliative care. Our primary endpoint, as I mentioned, is 4 weeks. And the additional follow-up time points are 8 weeks, 12 weeks, 6 months, and a year. And here's the measures that we're using for our study outcomes to measure the domains of traumatic stress, number, severity, and distress related to physical symptoms, quality of life, depression, and satisfaction with care. We're also collecting demographic information, psychiatric history, disease characteristics, and we are also conducting a survival analysis and economic analysis. And so the potential benefits for clinical practice are a deepened understanding of the distress experienced by patients with acute leukemia and helping us to develop interventions to alleviate it, improves psychological and physical well-being for patients with newly diagnosed or relapsed acute leukemia, and the potential to affect policy and best practices in the treatment of acute leukemia in Canada and worldwide. I want to thank you for your time today. There's my email address in case you'd like to reach out to me with any questions after today's presentation, and I'm happy to take any questions you have now. Thank you.
Thank you, Kyle. Thanks for an excellent presentation. And it's very good to see that our colleagues from Toronto are online with us. You are doing fantastic work in Toronto. And what I specifically like with your study is that it's an intervention study. We need more intervention studies in palliative care. We have been writing about that for 10 to 20 years. So I'm very happy to see that. There might be some questions, Olav.
Yes, we have one here. Do you include patients undergoing high-dose treatment and stem cell transplant as well?
Yes, we do.
You're actually including a broad spectrum of patients with leukemia?
Yeah. Anyone with a primary diagnosis of ALL or AML is, as long as it is a new diagnosis. For now, we're not including patients who are relapsed, just to keep the sample as homogeneous as possible, but we do hope to eventually expand to that as well.
I think it's another question from the chat as well.
What were the most common ASD, PTSD symptoms in the sample you talked about in the beginning?
So that's yeah. Okay, great.
So high levels of distress. Patients were highly distressed, showing high levels of arousal and attachment anxiety. So working a lot on attachment security was a main focus of the EASE-PSI intervention component.
Does the palliative care follow-up include?
So this is, it's focusing on things like quality of life, goals of care, looking at satisfaction with care, and looking at advanced care directives as well, working with the patient's caregivers, and a heavy focus on symptom management and control.
One group is getting standard care. Do you have any idea how many patients would get any kind of palliative care / psychology support in regular care?
So when we did our observational longitudinal study at Princess Margaret, we found that about 14% of patients, so that's in the usual care condition, were referred to psychosocial oncology. So a very low proportion, and only 3% were referred to palliative care.
So you should have a potential to actually identify two different groups here. I just want to round it up with a more methodological question. How do you control for carryover effects from the intervention group to the control group in a study?
Yeah, so that is a potential problem. However, what we found when we did our pilot study is that this was actually quite minimal, but we will be controlling for the provider providing the care when we do the final analysis.
Thanks a lot. Thanks a lot for an excellent presentation, good discussion. And we are really looking forward to the results in a couple of years, maybe.
Yes, absolutely.
Okay, so thanks to everyone for joining the session. Now we'll have a 15-minute break. We're running a little bit late, but I still think that we need 15 minutes break. So come back in 15 minutes. Thanks a lot to everyone. Welcome back, everyone. And now we are changing topic. The main topic now for the rest of the day is nutrition and cachexia. We'll start with 3 presentations invited, and thereafter we will have a panel debate, and we will round up today's last session with a submitted abstract. So the first presenter is Barry Lurd. He's in Edinburgh, I suppose, or he might be in Glasgow. I'm not pretty sure, but somewhere in Scotland. So Barry, it's good to see you online. Unfortunately, you couldn't come here, but next time we'll hope to see you here. You are one of the key collaborators within the PRC, and you will present the PRC Revolution study. So Barry, you are online, and even more than that.
Thank you, Stein, and thanks to the group for the invitation to speak today. And it's great to have nutrition as a core part of the PRC, recognising its importance in cancer care. I'm just checking everyone can see my slides okay. So, yep, slides you can see, perfect, good. So this is I'm going to present a study that's very much in its infancy, called Revolution study, which is a routine evaluation of people living with incurable cancer. I'm very much presenting this on behalf of a large group, of which I'll note them all at the end of the study. As Stein says, it's part of the PRC portfolio of work, along with our group here in Edinburgh that Mary Fallon and I work in. So it's hugely disappointing not to be in Oslo today. I'm very much looking forward to it. I was there a few weeks ago, and this is the Opera House, for those who don't know it, and this is the brand new Edvard Munch Museum, which is just opened, and I was hoping to try and visit on my trip over, but another time. And I'm sorry, the snow day as well. But there are sunny skies there, hopefully, and there are sunny skies today in Edinburgh, although it's almost as cold as Oslo, I feel. So cancer cachexia, as I mentioned at the start, it's important because, conservatively, about half of the 8 million cancer deaths per year are in cancers where cachexia is hugely problematic, including pancreatic cancer, esophageal cancer, and lung cancer. But yet it's not really included in the death statistics of any country. It's rarely, if ever, written as a cause of death on a death certificate. And usually when I give a talk about cachexia, I say there's no licensed therapy. Well, I'm delighted to say in Japan now there is a licensed therapy, anamorilin. But other than that, there's no other treatments and no standard of care. The group that I'm privileged to be part of is working on the MENAC trial, and there's also another up-and-coming study called the Multi-Anam, which my colleague and friend Tora Solheim will discuss very shortly. But we're still in a situation with cachexia where there's no real treatments available. So it's a huge problem for us. So why has it been slow research in cachexia? Well, often in the past, it was a prerequisite of oncology trials that they sort of took precedence. So cachexia trials, when they did rarely occur, tended to occur in the sort of late phase of disease. And they occurred, when patients often were too far down the line. Also, there was a sort of, aspect that you can't really do 2 trials at once. But what we're trying to do in the arena of cachexia is move things forward, where we're doing cachexia studies alongside people getting systemic anti-cancer therapies. There's also been limited pharmaceutical funding for this, and there's been a lot of regulatory failures. Drugs have tried to get to regulatory approval, and these have failed. Things like enobosarm and anamorilin, until very recently, has not made it to market. So we've got some major issues here with cachexia. Now, a big step forward in this was in 2011 when my late colleague and mentor, Professor Ken Fear, along with Stein Kosa and Vicky Baracross, amongst others, produced this definition and classification statement, an international consensus. And this was a real step forward, because what was tried to do here was trying to give cachexia, some structure. And it did two things. It came up with a definition, and this definition as Ken often told me, was not cast in stone, but was designed to be tested, adapted, and challenged as we went through. But also this classification, acknowledging that cachexia goes through 3 different stages of a pre-cachexia phase, cachexia to refractory cachexia. And what was interesting was that it says in this figure in the paper, at present there are no robust biomarkers to identify those pre-cachectic patients who are likely to progress further, or the rate at which they will do so. So what's really happened in the last 10 years is we've tried to make some headway into putting some, some more sort of evidence behind this. So Vicky Baracos and our team in Canada have been leading the way with a lot of this work. So this paper, published in 2015 in the JCO, looked at how BMI and weight loss affected survival, and it's essentially demonstrating in an extremely large cohort of about 10,000 patients here, that patients with a BMI over 28, so slightly overweight BMI, and minimal weight loss, had a much better survival than patients who had low BMI and greater weight loss, up to 15%. So sort of demonstrating here that both weight loss and BMI were important factors. So then we can take it to another angle. So Donald McMillan and the team in Glasgow have been pushing forward the inflammation sort of agenda here with cachexia. They've been saying that cachexia really should be defined on function, things such as performance status, inflammation using their Glasgow prognostic score, and nutrition to some extent. We can take it again a step further, looking at lean muscle mass, and this was a review that was done again by the team in Glasgow, where they tried to compare skeletal muscle index and skeletal muscle density between both curative and non-curative cancer types. And they argued here that muscle didn't change that much, essentially. In fact, it was almost endemic in patients, irrespective of whether they're curative or non-curative, cancer. And then we get on to further sort of moving it forward with the ESPIN guidelines on definitions and terminology, and where they defined chronic disease-related malnutrition with inflammation as a sort of cachexia, which some agree with, some don't. So at the moment, there's lots of different things happening with cachexia, lots of different definitions, and we're trying, as part of the PRC and with Vicky Stein and Mary Fallon and others, we're trying to try to pull all this together. But it was highlighted to me recently in both the ASCO guideline and also the ESMO guidelines, that in these widely respected and will be highly cited guidelines, cachexia is diagnosed just slightly differently. And it's really clear that we need to fully understand what is the real genesis and progression of cancer cachexia. So to go back in time to 1986, when the first Top Gun movie was released, when Tom Cruise was still in his 20s, Professor Ken Fearon wrote in his thesis, his PhD thesis, a reduced food intake is probably the main cause of continuing weight loss in the cachectic cancer host, and the incidence and mechanisms of an increased energy expenditure remain uncertain and may be different for each group of cancer patients examined. How they can see that this weight loss is probably key, and reduced food intake is important to that, but the mechanisms behind that were not really clear. So let's fast forward to 2021, where Top Gun's back. Tom Cruise is still flying. Tom Cruise is now still Maverick. And again, paper by my colleagues in Canada, Lisa Martin, Vicky Baracos, where they looked at a 12,000 cohort of trying to sort of add some sort of data to these earlier concepts. Where they took 12,000 patients and demonstrated that loss of food intake was a major component of likely to be cancer-related weight loss. But they say in their paper again, ultimately our understanding of the factors to cancer-associated weight loss will only be fully described when both food intake and alterations in metabolism are fully accounted for. These metabolic alterations are suggested to include inflammation, increased energy expenditure, excess proteolysis and lipolysis, along with other abnormalities. So we're slowly moving things forward to try and put this big puzzle of cachexia together. But it's often, it's what I very much like, it's more important to know what sort of person has a disease than to know what sort of person a disease has. And perhaps, that's extremely applicable to the area of cancer cachexia. It can leave us all feeling a bit of despair. This is entitled Melancholy by Edvard Munch. And when you look at all the cancer cachexia literature, there's some fantastic advances. But where can we go from here to try and move forward in a meaningful way? Oh, do you know why I stopped it? Okay. So I don't know what's happening. Sorry, this. So what we've tried, what we're trying to do or hoping to do is to try and move this forward through a form of prospective biorepository. A lot of the work that's been done so far has been on retrospective data sets, my own work included. So we developed this concept called Revolution, so routine evaluation of people living with incurable cancer. And there's been a lot of different biobanks and repositories out there, but very few have been sort of tailored towards cancer cachexia. So we want to try and use this as a platform approach that we can modify to understand various tumour types, and accepting that cancer cachexia probably differs dramatically between different tumour types, and also probably differs dramatically in the background noise of different cancer therapies. We almost see this as a franchise type of approach where we can look at it in one sort of cohort of patients and then adapt it. For example, we started it in patients in a palliative care setting, and we're now moving into lung cancer, and we're developing a surgical module as well. And we want to really try this as an understanding for the genesis, the pathophysiology, and multiple sequelae of cancer cachexia. So as I say, we're sort of moving towards the end of our pilot phase, and we're really now aiming to expand it through the PRC to try and get a large data set that we would share with the world. So we're going to take some of the key comments. Sorry. So I've got some technical problems here, but excuse me. So what are we actually testing? Well, we're accepting the fact that there are some key components we know in cancer cachexia. So let's start with body composition. Well, that's been a fundamental component of the definition. So we're going to look at bioimpedance and CT-based body composition. CT-based body composition being the gold standard, but bioimpedance, has moved on and potentially could be far more applicable in the bedside. We're also going to, further examine systemic inflammation, going from simple markers to more sort of in-depth cytokines such as interleukin-6, IL-1, IL-1 alpha, beta, etc. And Robert Paval will talk about that later on. Looking at physical function, both on measures of performance status and physical activity monitors, in addition to patient-reported outcome measures of quality of life. So at the moment, we're looking at these at both baseline, 6 weeks and 12 weeks, and we will adapt this as we go through, and including things such as cardiac echo, gut microbiome profiling and muscle biopsy as well. So we've demonstrated feasibility thus far, and that we've recruited patients, approximately 54 patients in our cohort so far, which have worked well. I'm sorry about this. We've recruited 54 patients so far, and it's deemed to be feasible, and these are patients in end stage in a hospice setting. We've demonstrated that there's some challenges with this. A lot of our patients have died, as we're looking at in quite a sick cohort of people, but the sort of outcomes we've assessed have been relatively straightforward to do. Patients have been quite keen to take part, and this is essentially a study where there's no benefit for patients taking part. We're also biobanking bloods, and as I say, we're moving on to do key sort of muscle biopsies and other aspects such as the microbiome. So in terms of our team, myself, Mary and Richard Skipworth are sort of leading it, and we're very delighted that Tora and Stein have joined us so far. We would very much extend this invitation. This is a study we want people to feel part of. So, let's just consider this an open invitation to question us and join us. And amongst the other people, mentioned on the slide here, who are integral in this going. At the moment, it's very much an Edinburgh-based study, but with hope to expand it to Glasgow and in other centres in Scandinavia and beyond in the future. So I'll finish here with Summer Night by Håvard Soberg, which is one of my favourite Norwegian paintings. The table's set for dinner, and we'll sadly it's not summer just now, but the Norwegian winter is equally as beautiful. So thank you all for your time, and I'll happily take any questions.
Barry, I think we'll move on without any questions and take the questions and discussions in the panel discussion afterwards. I didn't see any haggish on the table, and I'm happy for that. So we'll move on, and Barry, you have to keep online. So the next presenter is Tora Solheim from Trondheim, and she will present MENAC, Close to an End of Inclusion, Multi-Anem, How to Get Started. So you are ending and starting at the same time, Tora. I'm looking forward to listen to how you're going to solve this.
Well, we'll see. Are you seeing my presentation now?
Not yet.
Not yet. I'm sharing it.
I saw it, and then it disappeared.
Okay, it was just delayed, perhaps.
It's there.
It's there. Thank you.
Good morning.
Good morning.
These are my conflicts of interest. We all know the consequences of weight loss in our cancer patients, and that they are severe. They interfere with cancer therapy. It's responsible for a poor quality of life and decreased function. Patients with weight loss will live shorter irrespective of tumor mass or the presence of metastasis, and it will often cause significant psychological distress, affecting also patients' next of kin. We know that there's a lot of conditions contributing to weight loss in advanced cancer. The patients may have symptoms causing reduced nutritional intake, such as nausea or constipation. They may be physically inactive, making them experience inactivity sarcopenia. They might have side effects of treatment, such as radiation esophagitis. But they may also have this cancer cachexia that Barry was telling us about. As he described it, cachexia is a condition caused by tumor host interactions characterized by muscle loss, leading to impaired physical function, and often accompanied by reduced appetite and food intake. And in the consensus definition from 2011, it was defined that it couldn't be cured by nutritional intervention alone. Both of the studies we'll talk about are multimodal interventions. And by multimodal, we mean that it's an intervention using more than two or more modalities. They could be pharmacological intervention, nutritional intervention, or the exercise interventions. But why do we think that this is needed? Well, there are currently no treatments or standards of care for cachexia. There's a long history of failed unimodal trials. The pathophysiology of cachexia is complex, and the reasons for the patient's weight loss are multiple. And they often also change quite rapidly over time. And then we have our basic physiology. Sufficient nutrition and exercise is necessary to build muscle and improve physical performance. Our aims in these studies are ultimately that patients should not have this weight loss or muscle loss. They should have no appetite loss. And we hope they will have better quality of life and better physical function. And ultimately, we hope that this will lead to less side effects of treatments and then longer survival. But what are the evidence for this? Well, so far, not very good. There are some retrospective observational studies based from Cachexia clinics where they have observed the patients, referred to them. But there are challenges with all of these studies or observational studies. There are no controlled groups. There are many patients that doesn't return for a second visit, often because they referred quite late in the disease trajectory. There are often no clear description of the interventions. However, all of these studies report effect on weight, appetite, and quality of life, and that gives really room for optimism. Considering randomized controlled trials, there were a recent systematic review looking at this, and they found 5 studies, randomized studies, including patients with cancer. All of the studies reported some improvement on relatively relevant outcomes, but there were a huge heterogeneity in inclusion criteria, interventions, endpoints, etc. And very few studies were truly multimodal. Actually, in cancer, there were only one study that included all 3 different modalities. And that study was the PRC study, feasibility, the MENAC phase 2. In this study, we randomized 46 patients with non-small cell lung cancer or pancreatic cancer when they were receiving chemotherapy. They were offered 6 weeks with multimodal intervention versus standard care. And we saw the patients were interested and able to participate in this study, so it was feasible and safe. And we also saw promising results in terms of improving weight loss, body weight. Based on these positive results, we wrote the phase 3 protocol. And in this study, we randomized patients between multimodal treatment and standard care alone. And after 6 weeks, patients in the standard care arm are offered the multimodal treatment. The multimodal treatment is nutritional advice and supplements, including omega-3 fatty acids. It's a physical exercise program consisting both of resistant and endurance exercise. And it's also anti-inflammatory treatment with an NSAID ibuprofen. And the study is currently recruiting patients in USA, UK, Norway, and Canada, and 219 patients are so far included. We anticipated a 25% attrition based on previous studies, but as it seems today, the attrition is less than 10%. And our aim was to have 90 patients in each arm with registered primary endpoints. So ahead now, we are planning to soon finalize the inclusion in this study and the follow-up and prepare the data set. Then we will publish the main outcome. But in addition to the data used in the main outcome paper, we have gathered an extensive database with well-characterized patients and a biobank. And sites involved in recruitment will have the first opportunity to apply for use of this data. But we also invite all other PRC sites to apply for this. And all applications will be discussed in the trial steering committees. So we do hope you will take this opportunity. Unfortunately, we have seen that MENAC might not be the whole answer to cachexia because NSAIDs are not an option for everybody. we see that especially for pancreatic cancer patients, there has been challenges with recruitment because there are so many patients on anticoagulant treatment, on aspirin treatment, or have peptic ulcers that make it challenging to use the NSAIDs. And that is why we have started planning for a new study, which is called the multi-ANAM. This it's multimodal treatment, including anamorelin in patients suffering pancreatic cancer, patients suffering from cancer cachexia. Anamorelin is a ghrelin agonist, and ghrelin leads to increased appetite. It's an anti-inflammatory treatment, and it increases the secretion of growth hormone. It has been studied in several studies. The largest are Romana 1 and 2, which were phase 3 trials, including non-small cell lung cancer patients with weight loss. They found an increase in lean body mass, but no difference in hand grip strength, which was the primary endpoint. It did not receive a license, except from, as Barry told us previously, in Japan. And it's not quite true that it's only tested a single modality treatment. It has previously this year, it has been tested in a smaller multimodal treatment in the States, with investigating for effect on fatigue in cachexia patients. In the multi-ANAM study, we are including patients with primarily inoperable pancreatic adenocarcinoma. And we feel strongly about this patient group because they suffer so pronounced initial weight loss. And it's so difficult to counteract this weight loss. So we think this is a very important group to focus on. We will design this as a randomized open controlled trial, where the intervention will be nutritional counseling, oral nutrition supplement with omega-3 fatty acids, physical exercise program, and anamorelin. The control arm will receive standard care. The outcomes in these cachexia trials are very challenging. We have chosen body weight as it is a key characteristic of cachexia, easy to measure in clinical practice, understandable and relevant to patients and clinicians, and is also sensitive to both loss of muscle and fat mass. A secondary endpoints, we're thinking physical performance assessed with short physical performance battery and muscle mass assessed with CT scans. But of course, patient-reported outcomes are highly important. The present status of the multi-ANAM study is that we recently received funding from the Norwegian Cancer Society, and we are so very happy for that. So then now we can really start embarking on this. We need to finalize the protocol and obtain approvals. 4 centers has agreed to participate, but more are welcome. So please do not hesitate to contact us. Thank you for your attention.
Thank you, Tora. You will keep online, so we will discuss details and how we're going to bring it forward during the plenary discussion in a short while. So we'll move on to the next presenter. That is Jane Hopkinson. She's from the Department of Nursing and Interdisciplinary Cancer Care at the Cardiff University. And she will present on psychosocial considerations in the management of cachexia. So, Jane, the word is yours.
Good afternoon, everyone. I'd like to thank the organisers for inviting me to talk to you this afternoon. I'm going to talk to you about psychosocial considerations in the management of cancer cachexia. I'm Jane Hopkinson, Valindra Professor of Nursing and Interdisciplinary Cancer Care at Cardiff University in the UK. Let me begin by saying a few words about best practice in the management of cancer cachexia. We have two recently published guidelines. The first by ASCO says the goal of identifying and treating cancer cachexia is to improve treatment tolerability, improve survival, and optimize quality of life of patients with advanced cancer. The second guideline by ESMO provides a little more information about what's meant by quality of life. It says comprehensive treatment of cachexia requires multi-targeted and multidisciplinary approach. The primary goal is to meet the physiological and the psychological needs of the patient. This includes providing energy nutritional substrates and anabolic stimuli, as well as compassionate support to address dysfunction associated with the emotional and social aspects of eating. Those of you who know me and know my work will know that it's the dysfunctions associated with the emotional and social aspects of eating that I'm particularly interested in. For example, what we might do when there's disagreement within a family around what a patient might eat. So what is a multi-targeted approach? Well, cachexia treatment requires a multimodal approach aimed at relieving symptoms impacting on food intake, ensuring adequate energy and nutrient intake, minimizing catabolic alterations, supporting muscle training, and offering psychosocial support. In patients with cachexia, that means combining nutritional support with exercise training and psychological support, with anti-inflammatory interventions also considered. Two multimodal interventions that include a psychological and social support exist in the real world. So a multimodal intervention comprises components intended to work synergistically to support cachexia treatment or to address cachexia-related problems. And indeed, those sorts of interventions do exist. I recently conducted a scoping review to identify examples. It was a systematic search of Medline, Embase, CINAHL, PsycInfo, and the Cochrane Library. It sought publications about people who have cancer cachexia and receive multimodal intervention. It was limited to English language and January 2014 to March 2021 and looked just at adults with cancer cachexia. The search found 19 papers about multimodal interventions for either cancer cachexia or its defining feature, involuntary weight loss. So 19 publications about a multimodal intervention with a component of psychosocial support. For the review, a definition of psychosocial intervention was used, which was any clinician-led activity intended to have beneficial emotional, psychological, or social effect on health and well-being. In other words, any intervention that affects how a person with cachexia feels, thinks, behaves, or interacts with others in their home, their family, or their environment. What were the components of the multimodal interventions that included psychosocial support? Well, the psychosocial support components were combined with one or more of the following: pharmaceutical treatment of cachexia, pharmaceutical or non-pharmaceutical treatment of nutritional impact symptoms, nutritional support, exercise, or physical activity. Let's take a closer look at the different components. Beginning with the nutritional support component, where we can see some consistency here. We have almost all of the interventions offering nutritional counselling with or without a target for nutritional intake. And we also see a majority offering an oral nutritional supplement. There's concern to support energy and protein intake to meet the person's needs and the modification of usual foods. And then some of the reports go into details such as the advice was tailored to the person's preferences, their eating habit, eating preferences, or a prescribed diet was offered. Let's now turn our attention to the exercise components. So again, we see some consistency here. Almost all offering exercise advice with or without a goal being set for the person to work towards. We have nearly half also offering counselling, but this is counselling in physical activity or exercise, so quite distinct from nutritional counselling. And then 2 of the interventions also had a supervised part to them. Moving on to consider pharmacological interventions, we have 6 interventions offered a pharmaceutical agent for a nutritional impact symptom, such as constipation or pain. 2 offered pharmaceutical intervention for anxiety or depression, which can also be considered nutritional impact symptoms as they can suppress appetite. And 2 of the interventions included a non-steroidal anti-inflammatory to treat cachexia. Moving on to look at the psychosocial components. Here we see quite a variety of different things included within the psychosocial component of a multimodal intervention. So it seems as though there's not yet consensus on what's important to include. We have nearly half including an education component. So that's teaching in what cachexia is, what its symptoms are commonly, and how it might be managed. We have the offer of emotional counselling included in some of these interventions. That's distinct from nutritional counselling or counselling for physical activity and exercise. Some included education in self-management, such as advice on how to problem solve. We have things included such as relaxation to manage anxiety, motivational interviewing to support adherence to nutritional advice or exercise advice. Mindfulness included in 2 interventions to treat depression. And 1 included a therapeutic storytelling technique. Looking to involvement of carers, half of the psychosocial interventions involved carers, for example, in an education session. And I'd like to draw your attention to how few, just 3, included engaging the carer in promoting the intervention to the patient and supporting the patient through providing feedback or monitoring their engagement with the advice that they were being given around nutrition and physical activity. So how do psychosocial interventions help? Well, there are 3 distinct and complementary ways in which psychosocial component of a multimodal intervention can help patients. It can enable adherence to multimodal therapy, such as adherence to nutritional advice. It can aid emotional adaptation and coping, for example, supporting problem solving. It can treat comorbid anxiety and depression, and I've already mentioned the use of mindfulness for that purpose. Each of these ways in which a psychosocial intervention might help a person with cachexia is underpinned by a different theoretical way of thinking. So behavioural change theory and techniques can inform enablement of adherence, whilst education and stress management techniques can aid adaptation and coping. And I think of anxiety and depression as examples of stress response to cachexia. Does it matter? Does psychosocial support matter? Well, if we're concerned with quality of life, I suggest it does matter. Of course, support for physical function and oral food intake is important to support physical health and therefore quality of life. But the symptoms of cancer cachexia also disrupt emotion. They demand adjustment to the losses that the symptoms bring, requiring a coping response. They affect someone's sense of control over their illness experience. And then moving on to social factors that affect quality of life. The symptoms of cachexia can impact identity. For example, if somebody's physical appearance changes, that can challenge their sense of identity and therefore their quality of life. And their relationships make a difference to the quality of life. So the way in which their family carer is coping with the disruption caused by the symptoms of cancer cachexia makes a difference to the patient's quality of life, as does the carer's response, understanding of the symptoms, for example, whether or not they consider that they're volitional, and that can contribute to conflict in the home. Moving on to towards the end of my presentation, I'd like to say a few words about how psychosocial support might enable physical restoration and support quality of life in cachexia. I have here a figure with psychosocial support in the centre, and it shows 2 cycles. The first cycle is of psychosocial support that can motivate adherence to something that I've called practical actions, so such as adherence to nutritional advice or advice around physical activity. Nutrition and physical activity both supporting physical health. And that practical action can create a sense of positive emotion in the person with cachexia, sustaining their valued sense of self. And if we can set up a feedback mechanism that includes the family carer, then it can also support connection between the patient and others important to them. They then become part of the psychosocial support that enables another cycle of motivation and adherence to practical action for physical health. Let's now look at the bottom cycle. So we have psychosocial support that might be education that enables understanding the cause of cachexia and its symptoms, thus mitigating distress and aiding adaptation. So in this way, psychosocial support can enable emotional coping. Emotional coping can lead to a sense of control over the illness experience. And when others recognise that sense of control, they can give feedback that supports resilience. It recognises the strengths of the person in being able to cope emotionally, and again becomes part of the psychosocial support that might continue that cycle of adaptation and coping and a sense of control over the illness. So I suggest 2 cycles that are sustainable through psychosocial support. But this is also a figure of 8, in that if someone gains a sense of control over their illness experience, that may go on to motivate them to adhere to physical activity and exercise advice. So here I'm presenting a whole system of psychosocial support for enabling physical restoration and quality of life in cachexia. So my last slide, I hope this afternoon I've made a case for psychosocial considerations in cachexia and argued that psychosocial interventions can empower the patient to become a partner in their treatment, enable adaptation and coping, and enhance quality of life. So thank you for listening to me this afternoon. If you have any questions, please do get in touch with me. This is my email address. Thank you for listening.
Thank you, Jane. Thanks a lot for a very comprehensive presentation. We will wait for questions and discussions until we have heard the last presentation. So now we'll take a short break. We will limit it to 5 minutes. So please keep on, don't fall asleep, and come back in 5 minutes. So see you then. Welcome back, everyone. Now we are moving to the last presentation in this session. And I'm very happy that we have another presentation from Canada. Vicky, are you still awake? It's pretty early in the morning in Edmonton. You will present implement muscle mass and strength testing in clinical research. Is that something we should do? And if so, how should we use the results in clinical practice? So Vicky Baracos from Edmonton, Canada, professor in palliative care, palliative medicine, and she is one of the leading figures within research in cancer cachexia. So Vicky, the word is yours.
Thank you and warm wishes from Canada. Can you see me and see my screen?
No, we just see VB.
Okay, these meeting controls are not making me happy. Now can you see my screen?
And we'll now we have Vicky online. So please, Vicky, go ahead.
Thank you so much. I want to give everybody my warm greetings from Canada and express, as did Barry and others, I sure wish I could come to Norway, and I hope that will happen sometime soon. Now to muscle mass and strength. About muscle mass, you could first ask the question, why do we wish to measure it? And it's so highly associated to important oncological outcomes, patient's function, treatment response, complications of chemotherapy and surgery, mortality. On that point, there is so much evidence now that there are even, I think, about 35 meta-analyses on the subject. Another reason is that measurement of muscle mass is endorsed already since more than 5 years in oncology nutrition clinical practice guidelines. And it's really important to understand that this muscle mass cannot be accurately detected by screening approaches. I'll explain more about that later. And a particular case, sarcopenic obesity, is an important risk category, but it is otherwise difficult to detect without specific measurements. Now, as to how to make those measurements, I would argue that at this point, with nearly 700 publications on the subject, it seems obvious that we should be using the oncological images, in which we can highly specifically identify muscle tissues, organs, and every tissue, in fact, and very precisely quantify them. So in oncology, this is the gold standard. In body composition, this is also the gold standard approach. And for that approach, we already have in oncological settings a convention for doing so. And the convention relates to the fact that our images are not generally of the whole body. So the convention is to use single axial images anchored on a vertebral landmark, the third lumbar vertebra. And that is because at that level, the muscles area of the different abdominal and paraspinal muscles is in fact highly correlated to the whole body muscle mass. So we're using that as a standard way for the time being. So once you have those measurements, your eyes can be opened, and what you see when those when that vision is available is you can take people as these 6 women, all with locally advanced or metastatic colon cancer. I take these 3 as examples of 3 women of identical body mass index to one another, but with evidently, obviously, highly diverse level of muscularity. Likewise, my upper illustrations are 3 women who are indeed extremely sarcopenic. So they come from the bottom of our sample of 700 consecutive women patients, but you can see they have extremely variable muscle mass. And you can appreciate with this sarcopenic obese woman in the extreme how difficult it might be without imaging to detect this severe muscle depletion in context of the large fat mass. So can we do this? Do you want to do it? Maybe you would like to. And I would just like to emphasize that if your radiology department cannot offer it at this moment, they might be able to do so sometime soon. And that's because these methods are being adopted and evaluated with radiological methods, including the application of artificial intelligence to rapidly, I mean in seconds, to automatically landmark, I mean find the lumbar vertebrae in question and segment precisely muscle and then different adipose tissue compartments. These methods, at best, at this time, are fully automated and in 97 to 98% of images perform as well as a trained radiologist or expert in musculoskeletal anatomy. So that's going to be coming. So with that on the doorsteps, I'm taking you to some implementation ideas that come from the world of oncology nutrition. So here I'm going to start with why healthcare professionals in oncology nutrition are interested in using computed tomography to diagnose cachexia and sarcopenia. And here's the main point. In this very nice study from Aoife Ryan's group in Ireland. So nutritionists use malnutrition screening tools of different types. You will be familiar with these. So importantly, patients who score 0, that means they're perfect, no nutrition risk, whatever, 55% have occult sarcopenia when you look at the images. At worst, the malnutrition universal screening tool, 61% have sarcopenia, and at best, the nutrition risk index score, 14%. What this is telling is that conventional nutritional risk screening tools completely miss the presence of occult sarcopenia. So the nutritionist would be motivated to get into this world. They're healthcare professionals whose role is to provide nutritional care. They could use CT defined body composition in the nutrition care process at different levels, and there are leading nutrition societies, the American and European societies of parenteral and enteral nutrition include loss of muscle mass as diagnostic criteria for malnutrition since 6 years ago. So it's part of their mandate and could be construed going forward as an advanced competency within the clinical nutrition sphere. So they have this challenge, as pointed out, the inability to detect certain aspects, especially of obese patients. And so the vision would be to have CT image analysis in assessment, sarcopenia included in the nutrition diagnosis, and that lends itself in the general direction of high level or high quality of protein or both to address that problem. And then the imaging could be used to do nutrition monitoring and evaluation of that nutrition plan over time. So how would you go about doing that? And I would like to tell you that researchers are doing this, and that you will soon see publication in which registered dietitians have adopted a pathway of knowledge acquisition, training, validation of competency, including examination, certification, and continuing education, such that dietitians can integrate this CT-defined body composition to their practice. So here's a couple of instances where that's happening, just to give you a peek. So here is a nutrition CT body composition report created by a dietitian who has entered the imaging system, downloaded the image, and quantified and done the reporting. So this report is from our center. This is an oncology dietitian in a cancer surgical service. Here is reported the nutrition demographics, height, weight, BMI, age, sex, diagnosis, stage, CT date. Here's the image, here's the derived value, and here is the report. So what this report does is it takes the distribution of the muscle mass metrics from the population and indicates the location of this patient. She's an 82-year-old woman, and she has 1.2 standard deviations less than the median value for for women in their 80s from this population. So she's quite sarcopenic even for her age and sex. What is this pink band? This pink band is placed on the report because in the literature, in this sample, in this patient population, women in this band have been shown to have increased length of hospital stay after their cancer surgery. So when the dietitian hands this report to the surgeon can see that this patient is sarcopenic and in the risk category for increased length of stay. This report can also be used by occupational therapists and physical therapists for understanding of their habilitation, prehabilitation, and post-surgical rehabilitation, and so forth. So my second example, and this is just a short one, is to point you in literature where this group has been using the nutritional, including CT body composition over time. These are patients with locally advanced cervical cancer during treatment with concomitant chemoradiotherapy. You can see here gross changes of each one of their body composition over time. And my main point is that this is being done by dietitians out there, in this case in Mexico, following their patients in usual care. Now I'm going to go to my other subject, and this will be a short description of muscle function in clinical care and research with several main points. Muscle function, I would put to you, has several scenarios. Acute cancer surgery is a scenario of a brief, severe impairment of muscle function with our intention to get people functional again and discharged from hospital. A completely different entity is the unresectable disease, where we have a whole cancer course, often treated with palliative intent, that goes all the way from whatever functional capacity each patient had at the beginning to zero function in the end of life. And that is made complex and difficult by the magnitude of the range of physical functioning over that course, and also by comorbid conditions that make this additionally more complex. It is impossible to imagine a single category of physical functioning tests that would describe that complete trajectory. So we have a great number of different approaches, including quality of life tools, walking tests, actigraphy, a variety of functions over a very large scale, and many outcomes of function that relate to patient ability and quality of life. I would put it to you that for most of these, we do not have the information that we need, but I'll make an example of one, and I think this is important. Here's a large study of non-small cell lung cancer patients evaluated for physical functioning by the physical functioning domain of the QLQC30. They have done for male and female that physical functioning domain across the entire distribution of the metric I spoke about before, L3 muscle index. Here you can see over a large range of L3 muscle index that measure is insensitive. So there comes a point, though, with a steep inflection in male and in female, over which the physical functioning by this measure decline rather steeply. So I think this range of data. So the functional outcome related to this full range, extensive range in well-powered populations is what we need to shoot for in order to make these all of these different measures useful, and so that we can understand their sensitivity and specificity. So here I'm going to finish by just underscoring we have such a high diversity of physical functioning in patients with cancer across the trajectory and of the underlying pathophysiology of their physical functioning. We do not have any agreement on relevant clinical tests of physical functioning that we can use. There is much needed development in this area. And I would press to you, maybe in the vein stressed by Dr. Hopkinson, that as we go forward to assess and improve these measurements, that we might want to think most carefully about those which are meaningful to patients and which really reflect what they desire to be their physical functioning across their cancer journey. And with that, I thank you so very much.
Thank you. Thank you, Vicky. Now, while the presenters, Barry Lurt, Tora Solheim, Jane Hopkinson, Vicky Barakos, and as well Per Sjögren, who is with us from Copenhagen, while you're making you ready for the panel discussion, we will have a Mentimeter nutrition question for you. So if you look at the chat and you go to menti.com and you use the code 59444382, you'll find it in the chat and you will be able to answer the question. It's just one right answer. What do you think is the most important parameter for diagnosing cachexia? So please enter your... Here we have a muscle person, two muscle persons. Three. This is interesting from a psychological and presentation point of view. Oh, weight loss is coming up. Okay, guys. So it's interesting to see that no one of you want to talk to the patient and ask the patient about patient-reported outcome measure, anorexia. You all want to measure something. That's interesting. And here we see that weight loss and loss of muscle mass are at the highest level. But also inflammation. Still no one wants to talk to the patients. That's fine. So this is something we can discuss during the panel. We'll keep on for another minute and then we'll move to the panel. So Barry, Tora, Jane, Vicky and Per, please be ready. And I know that we also have quite a few questions in the chat. Olav, you're ready?
Yes.
Yes. And if any of you have comments or questions, please post them in the chat. So I think we're rounding it up. So the score is the highest for weight loss. Number 2 is loss of muscle. Number 3 is evidence of inflammation. And as I said, no one are actually scoring anorexia, which is more like a subjective symptom. Okay, so I think we'll round up the poll here and move to the panel. So while I'm waiting for the panel, I hope that, okay. So Barry, Tora, Jane, Vicky, and Pierre, do you hear me? I believe.
Yeah.
There
Yes.
you are.
Can you hear me? Can you see me?
I don't see you, but I see Pierre and Jane and Barry and Tora. So you are probably hidden somewhere in the snow, Vicky.
I'm not understanding. Should I be in the live stream or in the speaker room?
You are in the right place, but you just need to turn on the camera.
My camera is on. I can see myself on the screen.
Okay, that's fine, but we can hear you. So maybe we should start with some reflections from the panel. Now you have heard 4 excellent presentations. Maybe, Barry, do you want to start to have some reflections about the topic nutrition and cachexia? Where are we? Where to move forward? Barry, are you there? Maybe someone else want to answer.
Sorry, you went quiet there. I couldn't hear what you said. I don't know what you said. No.
Okay.
Can you?
Pierre,
We have not heard the question.
Okay, you didn't hear the question. Okay, so I had like an overall question. Now you have heard excellent presentations. So I was wondering we'll start on a meta level, and how do we move the area of cancer cachexia forward? Do we need more clinical studies? What type of studies? Do we need better classification? Do we need to bring, for example, what we know into clinical practice? So all of the above or whatever. How should we prioritize?
But you could make the argument that we cannot progress this field unless we progress on all of the fronts. So which piece do we not need? Which piece can we deprioritize? I mean, we want to do clinical studies. We want to make measurements on people. We cannot do that unless those persons have been understood enough to enable their participation in our studies, and that's a gap. And there's all kinds of things we like to measure. I understand from the Mentimeter that the empiricists are there with their measuring stick going, I like to measure this, I like to measure that. But there's so much work to be done. And we need the interventional studies, we need the observational studies. I think that it's a fair statement that the cancer cachexia research is so thin on the ground on every level that, in fact, the paradigm of the PRC to cooperate is the most important thing on the page here. So we few can get together and make these advances.
May I give the word to you and hear what are your considerations?
Yeah, I think it depends what we want to do. So, I mean, there's seeking the treatment and cure for cachexia, and there's helping patients now while we await for that treatment and cure. And I think they're interrelated. I agree with Vicky, we can't do one without the other, because we need to be looking at what we can do now to improve people's lives, because that will help build the head of steam that we need to get the investment and support for the science that will eventually find the cure.
Well, I consider myself a little bit of an outsider in this society. My main interest has been pain throughout the years, but what I think about when I hear all these splendid talks, because it was a wonderful session in my mind, is that of course it is a multimodal treatment approach that is needed in these patients. That is quite clear to me, and I was very happy about Jane's talk, because I think this is something that is forgotten, and even forgotten in the RCTs. I think we should consider the psychosocial aspects like we do in pain and all other phenomena, symptoms, and so on in palliative care. But what is needed here, and in contrast to, for instance, pain, is a pharmacological treatment that works. I know there's a lot of problems with characterization of the syndrome, etc., but there's no efficient pharmacological treatment that is the basic. For instance, in pain, you have the opioids, and then you build a multimodal treatment of the patient with psychosocial, spiritual intervention. You put on exercise, you put on a lot of things, but there's really a need of a pharmacological treatment. And to Tora, I would like to say you are really searching for that approach in a wonderful way, and I'm very, very impressed by your resilience keeping on, for instance, the MENAC study. I think I've heard about that for many, many years. So that is basically my reflection.
Tora, what will be the results from the MENAC study?
I wish I knew. We're very much looking forward to seeing them. Hopefully, within next year, I will know.
How many years do we need to analyze this data? I think people are asking for the data as soon as possible. And when are you, or when are we going to start the multi-annum study? And we should probably, in my mind, it's more like a reflection or a question to you. We couldn't go on for another 5 years to recruiting patients in the multi-annum. We probably need to speed up.
We know it would be good to have more centers to be able to get results done quickly. So I hope that people take the invite to join us for the multi-annum study.
And Barry, you presented the Revolution study. Is it going to be a revolution, or what type of information? Let's say that you recruit 5 to 10 different centers around the world. What type of data can we expect to get from the Revolution study to help us to reach the goal that, for example, Per is pointing towards?
Yeah, thanks. Good question, Stein. I think one of the I guess the aims of it is to look at longitudinal data. A lot of the work that's been done has been single cross-sectional studies of data that wasn't really designed for the purpose. So I think having following the trajectory almost of somebody when they present with a cancer and where they go down that surgical pathway for curative treatment and potentially recur, or somebody who presents with metastatic cancer, how to follow these patients at different points in their journey and try to really get a sort of holistic characterization of how these different factors change, how weight loss changes, how inflammation changes, how muscle changes as well. Because we know a lot of the main players here, but I don't think we're quite clear how, as well as how they talk to, how all these different concepts talk to each other. So I think it's an interesting way forward. I also have an observation and a comment or a question, please, to Vicky, if that's possible. Yeah, Vicky, I think you made an excellent point about the screening, and it's both encouraging but also slightly pessimistic that it's taken the dietitians to do these scans to tell the oncologist what's important. How I was thinking during your talk, surely as part of any cancer MDT now, we're busy staging the TNM classification of our patients. We'll then do genetic subtypes for these patients. How can we get the body composition analysis routinely discussed as part of post-staging in our cancer MDTs?
But you know, we've got a long way to go on that, or maybe a short way to go, Barry. I mean, you raise a very good point. I think one of the things that is there's a barrier to that, and the barrier is the adoption of the CT body composition measures within oncological radiology. And one of the things that's going on right now is really interesting. So there's a big initiative based in Montpellier, France, and they want this. That says a research-intensive French cancer center, and they've decided to develop a collaboration with a major French service provider of radiology desktop software. So they're moving in the direction of integrating these automated segmentations that can do single slices, full 3D, integrating them in their clinical workflows. And that means connecting them directly with their PACS system and running it in real time within the radiologist's desktop. There's also at least one international company developing those methods that will be PACS compatible and go into cancer centers. So there's lots of places where the cancer care organizations, services, medical oncologists, surgeons are very interested in having this, but it has to come through. There's no way other for it to come through than through diagnostic imaging. And at the point where diagnostic imaging departments start to go live with this methodology, it can be go into clinical workflows, everybody can have it. If I could ask you a question back, maybe this is a question to Barry and Tura about inclusion. If I wanted to participate in your prospective longitudinal study, Barry, didn't quite fully hear or catch, because my brain is old, what point in the cancer trajectory does the eligibility begin? Like, where does the recruitment start? You said something about poor survival, so I was wondering if that wasn't a bit late. And also for Tura, I just want to ask about why you would limit to pancreatic cancer at the point that you don't know the results of the MENAC study.
Okay.
Good question. So Barry, you first.
Yeah, thanks.
Quick answer.
Yeah, so the feasibility stage, we've done it in people in a hospice, basically. So they've been near the end of their cancer journey, but we're basically going to push that back to patients when they get their MDT diagnosis of cancer. So that MDT diagnosis of cancer, they may go down a surgical route, or they may go down a best supportive care route, or they may go down a oncology treatment route. So we're moving it. We've just done a feasibility, which works, but we need to get our entry point clear. And I think that's going to be MDT diagnosis of cancer.
But Barry, don't you think that we should see if we can establish a group of centers who would like to participate in a prospective cohort study?
Absolutely, Stein. Absolutely, and
discuss the point of entry, maybe.
Yes, absolutely. No, this is just what we're thinking. But yeah, I couldn't agree more. And very, very looking forward to having these discussions with you, Vicky, and everyone else as we develop this piece of work. We've merely planted a couple of seeds, and we're now want to get this growing. So.
Tura, before we go to the chat, because there are quite a few questions in the chat as well. So Tura, why are you limiting it to, or why are we limiting it to pancreatic cancer?
Well, they have a very pronounced initial weight loss, these patients, and they have very poor prognosis, much worse prognosis now than the lung cancer patients, and much less opportunities to treat their cancer. So they have a weight loss that is especially challenging to counteract. So that's one reason. Another reason is that it has been much less investigated with anomorelin use. And it's also What was my last point? I lost my trail of thoughts. I'm sorry.
Okay, it might be somewhere in the sky. But I was thinking, I was thinking, Tora, why couldn't we also include maybe patients who have relapsed on first-line anti-cancer treatment with non-small cell lung cancer?
I think it's important to try to get a homogeneous sample, because many of these trials has been so difficult to interpret. So to try to limit the diagnosis and making them easier to interpret later.
Thank you. Now, Olav, do we have any questions from the chat?
Yeah, one question from one of the participants is, why have there only been a handful of studies that have attempted to target pre-cachexia?
Okay, this is a good question. Maybe...
Happy to have a stab at it. The thing is, you know, in the definition classification 2011 paper, the criteria for entry of pre-cachexia was still quite loose. So I think we're not really sure what pre-cachexia is. I would potentially argue that anyone with a bad prognostic tumor presenting a lung or a pancreatic cancer is pre-cachexia until proven otherwise. Very interested in Vicky's remarks on that as well.
Jane could follow it up.
Trajectory data. So this is a vote in favor of studies like EPCCS, studies like Revolution, where we begin to understand how cachexia goes over time. And then it begins, at the point where it begins, we'll find that, and we'll find that which is a predictor of the emergence of cachexia. What is the biomarker for that? And once we know that, we can position to pre-cachexia, but earlier is better. And I also agree 100% with Barry's take on this. There are certain cancers and stages at which you could rightfully assume that everybody is going there sooner or later.
Jane will be the last response in the panel, because the producers here telling me that we are running over time. So Jane, do you have a final comment?
Okay. Yeah, thank you. I'm not persuaded that at the moment we can distinguish pre-cachexia from people that aren't going to go on to get cachexia. And what we probably need is a predictive tool that can be used in clinical practice. And then perhaps we'll get more study of the pre-cachectic phase once we have a way of recognizing it.
Okay, great, thank you. And then I can inform all the participants that quite a few of us within the organization, within PRC, are now have started the work to improve the classification system from 2011. So just follow up and for the next PRC conference in order, so we might have some new data for you. And then we'll move to the submitted abstract. And it's on examination, the relationship between cytokines and cachexia in incurable cancer. And the presenter is Robert Paval. He's a PhD researcher at the Faculty of Health Science and Sport, University of Stirling, UK. So, Robert, please.
Hello. Can you hear me?
Sure.
Thank you. First of all, thank you for having me. I'm glad to be presenting my work. I wish I was in Norway to do this, and I hope I'll be there in Denmark next year. Let me just share my screen. Can you see my slides?
We have learned 2 new words in this COVID. That's share screen and unmute.
That is true. My laptop is acting slow, so we might have to wait a couple of seconds. Let's just see. I apologize for the wait.
We'll take the time we need. While we are waiting to get this share screen up and rolling, I would like to invite you to think about if you want to participate in either of the studies which has been presented today. Please give us a note, email, SMS, whatever. You know how to reach us, or you can go directly to the presenters and talk to them. So I think that will be very, very helpful. Now the screen is up and rolling, so we'll try again.
Can you see my slides now?
Yes, we do.
Lovely. So, hi everyone once again. My name is Robert Pavel, and I'm currently doing my PhD at University of Stirling in sunny Scotland. My thesis is looking at the role of intellectin and other adipokines in cancer cachexia. And my presentation won't be as visual as the previous ones, as I will talk about one of my systematic reviews that evaluated the role of the relationship between cytokines and cachexia in people with incurable cancer. So cancer cachexia is an unmet clinical need that affects more than half of patients with cancer and accounts for 20% of the cancer-related deaths. The systemic inflammatory response is mediated by a network of cytokines and has an established role in the genesis and in the maintenance of cancer, as well as in cachexia. However, the exact role of cytokines in cancer-associated cachexia is not fully understood yet. To cover this gap in the literature, we designed a systematic review that aimed to examine the relationship between cytokines and cachexia in people with incurable cancer. To do this, we searched 6 databases for studies that were published until January 2020. The titles, the abstracts, and the full text studies were reviewed independently by Dr. Rebecca Patton and myself, who are joint first authors on this paper. The included studies measured cytokines and their relationship with cachexia and weight loss in adults with incurable cancer. After the screening phases, 3 authors assessed the quality of the selected studies using the modified Dow's and Black checklist. And the results we got, a total of 1,277 patients with incurable cancer and 155 healthy controls were analyzed in the 17 eligible studies. The most common types of cancer were lung and pancreatic cancer, although various other types such as colorectal, breast, or gastric cancer were analyzed. The mean quality score of the papers from the current review was 7.8, where 0 was the lowest and 10 was the highest score a paper could get, indicating that the studies incorporated evidence of moderate to high quality. The included studies measured 31 cytokines, of which IL-6, TNF-alpha, leptin, IL-8, and IL-1 beta were the most common. IL-6, TNF-alpha, and IL-8 were overall greater in cachectic patients compared to healthy individuals. Also, we observed that IL-6 levels were higher in cachectic participants compared to non-cachectic patients. And the other cytokines did not demonstrate any significant difference between groups when patients with cancer cachexia were compared against non-cachectic patients or against healthy participants. As you probably noticed, and as I have mentioned earlier, my presentation was not as visual as the previous ones. One of the reasons for this is the fact that we were not able to conduct a meta-analysis. The available body of literature could not be meta-analyzed due to the high degree of methodological heterogeneity, as well as the lack of transparency and failure to meet basic standards of data reporting. Specifically, 5 of the studies we included only reported p-values, and 2 studies did not report any measure of dispersion, such as standard deviation or interquartile range. Also, several studies examine multiple cytokines and only display data for statistically significant relationships. And the use of these practices in the literature leads to biased reporting and to the inflation of type 1 errors in the systematic reviews published and in the literature in general. We also observed, and this was discussed throughout the presentations earlier, that the definitions of cachexia and weight loss thresholds were highly variable across studies. A third of the included studies defined cachexia as suggested by Ferran and colleagues in 2011, while several studies referred to cachexia as a syndrome that implies losing more than 5% or 10% body weight. Furthermore, some authors did not use the term cachexia, but instead classify the participants according to the amount of weight lost during a period of 3 to 6 months before the study, or according to nutritional sufficiency. The criteria according to which participants were grouped are clearly not homogeneous enough across studies, and this, together with the previously mentioned aspects, made it impossible to meta-analyze the data. We ended the review by highlighting areas where research could be optimized. And as some of you highlighted before, future studies should be longitudinal with an extensive characterization of the cachexia phenotype to allow better understanding of the relationship between cytokines and cachexia. Additionally, future research should integrate surrogate markers of the inflammatory response, such as acute phase proteins or cytokine receptors. Adding these markers as a complementary measurement would definitely generate a more accurate overview of the inflammatory state and of the cascade of immune events underlying cancer cachexia. And really important, increasing homogeneity in study design should be a priority for future studies. This can be achieved by grouping participants according to established criteria, such as the Ferran consensus or the modified Glasgow prognostic score. Most importantly, regardless of the study design chosen by the researchers, by the authors, it is crucial to describe the methodology and the results in a transparent manner. Specifically, all measured variables should be reported and not only the significant results. And I recommend including complete data sets at the end of the manuscript to increase the reliability of a study. Authors should go beyond p-values and must report data using central tendency values or effect sizes alongside measures of dispersion. Also, the blood collection methods, the type of assay used to measure biomarkers, and the sensitivity of the assays should be described in the methods section. And to conclude, to summarize, these findings suggest that the network of cytokines, commonly IL-6, TNF-alpha, and IL-8, are associated with the development of cachexia. However, this relationship was not causal, and future studies should opt for longitudinal designs with consistent methodological approaches, as well as adequate techniques for analyzing and reporting the results. Thank you very much for your time, and please do let me know if you have any questions.
Thanks a lot, Robert. A very important overview, and I think that you are raising some very important methodological issues with regard to study design, maybe sample size, maybe the limit related to heterogeneity, etc., etc. So maybe we have been talking about that we need a classification system to better understand cachexia. Maybe we need some sort of guidelines on how we're going to run studies for the next 5 to 10 years, so we can run meta-analysis and try to learn from each other. So do you have any suggestions or any ideas on how we're going to, or how we can improve for the next 5 to 10 years?
In terms of, I'd say one of the most important things would be to group participants according to set criteria. Although I'm not a huge fan of putting things into boxes, I would love to see similar studies in terms of grouping criteria. So either using the Ferran consensus or the modified Glasgow prognostic score, because in order to be able to meta-analyze data in 5 and 10 years, this would be one of the first steps, trying to have similar groups, because as long as we don't have these similar groups in terms of classification, it would be really difficult to meta-analyze it in the future. And for better understanding cachexia and defining it, and I assume, as most of the speakers before me, it would be ideal to conduct longitudinal studies to observe how it evolves throughout cancer.
Mhm. Great, thank you. Olav, do we have any questions in the chat?
No.
No, there are no questions in the chat. Then time is running out. We are almost on time. So thanks a lot, Robert. Thanks a lot to everyone who have contributed during this day. I think we have had fantastic presentations, good discussions, and undoubtedly we have something to work on for the next couple of years, maybe the next 5 years, Olav, or what do you think?
Yeah, I'm quite sure.
You're quite sure, okay. So tomorrow we are shifting topics somewhat. So welcome back tomorrow. Tomorrow we will start with the topic about integration and implementation. So we will discuss the results where the palliative care and patient-centered care is integrated into cancer care as such. If not, how can we possibly have a new or a better strategy, which is probably related to implementation science? Then the next part tomorrow will be about pain and pain treatment. So I hope that you will stay with us for tomorrow. And again, thanks a lot to everyone. Thanks for everyone who listened, who participated. And have a nice evening and travel careful back home. So see you tomorrow, and that's all for today.